morning, ladies and gentlemen, and all my senior teachers and all the delegates. I welcome you all on behalf of Maharashtra State Chapter of Association of Physicians of India. This new, or I should not say it's new, it was there, but unfortunately overtaken by diabetes and other sessions. And we will be going through all the basics of at least how to conduct a clinical research for all the physicians who are working in Mumbai and around. So welcome all. Just before the start of session, the Dean of Indian Council of Physicians, Association of Physicians of India has sent his message. So we'll just play, that is a 2-minute message, and then we will come over to the proper session. Few people are still having their breakfast, so I said keep better finishes this off so that we can, they can also join from the beginning itself. Thank you.
Hello friends, it gives me immense pleasure to extend my warm greetings on the occasion of ICP Academic Outreach Program, Demystifying Research, a unique workshop for practicing clinicians being organized in Mumbai in collaboration with Maharashtra chapter of API. Clinical practice and research are two sides of the same coin. Every patient we treat presents an opportunity to ask questions, seek answers, and generate evidence that can transform healthcare. Research is not the privilege of a few academicians. It is the responsibility of every physician committed to improving healthcare. The Indian College of Physicians have always believed that nurturing a culture of scientific research is fundamental to advancing the standards of medical practice in our country. Through this workshop, we aspire to dispel the myths surrounding research, simplify its methodology, and inspire clinicians to translate their rich clinical experience into meaningful scientific contributions. I congratulate Dr. Nikhil Balanke, Chairman Maharashtra API, and Dr. Amit Saraf, Secretary Maharashtra API, for their vision and commitment to academic excellence. I also commend Dr. Subhashri Patil and Dr. Rakesh Badade, Joint Secretary ICP, for organizing this important initiative, which reflects the shared mission of API and ICP to promote lifelong learning and evidence-based medicine. I extend my best wishes for the grand success of this academic initiative and encourage all practicing physicians to participate enthusiastically. Thank you so much. Jai API, Jai ICP.
Thank you so much, sir, for that message. I would like to once again welcome each one of you for this research workshop called as Demystifying Research for Practicing Clinician. This is basically an initiative for the hand-holding of research-life clinicians to understand the research nuances and the basic steps that one need to follow. It's such a pleasure and privilege to have such esteemed faculty like Dr. Avinash Supe sir, Dr. Nithya madam, Dr. Mangesh Devaskar, Dr. Nikhil Balanke, Dr. Natkar, and my co-colleague Dr. Rakesh Badade helping me out to execute this workshop. I would like to start by telling you the inception of the research group that we are trying to form. Basically, once I tried to attend one of the conferences wherein I wanted to attend it as a faculty. And I requested one of my pharma colleagues to push in my name as a faculty so that I can attend the conference and I can also end up meeting some of my friends and socializing. Probably the intentions were not right for calling out. But what the organizing committee organizer ended up telling us that, Madam, you cannot be really called as a faculty. Barring that, you are a practicing clinician, there's nothing to your credit that you have to be called as faculty. You have no research, no publications, you're not an orator, you have not been a faculty at many conferences, so there's nothing attractive about your profile. So what I realized is that it definitely probably is important to raise about just clinical practice. We all need to think beyond clinical practice. Even if we are a good clinician who knows us beyond the area where we practice, and probably few fellow clinicians who practice with us, if we want to be acknowledged, recognized in our community, what is important is what we contribute in the form of research, in the form of publication. How much are we quoted? How much are we acknowledged for the work that we are trying to do? And this is one initiative that is going to help all of us. We have this group called as Sugar Science Studio. The inception of this group happened because with this agony that I had, I went to Dr. Mangesh Devaskar, sir, and I told him, sir, this is how it is, and I think I need to improvise. Can you show me a way out? And he said, why not? If anybody else can do it, you can also do it in your private practice. It's quite doable and possible. And that's where he told me that you should start thinking about small research topics. Try to form a group and try to form a team, and that will help you lead the way. And that's how we had this group, which is called as Sugar Science Studio, with a QR that you can see on the screen. You can scan the QR and become the part of the community. When this group was formed 2 years back, we started doing small research and made our way to publications. And I'm glad to tell you, my friends, that last year, 23 abstracts were internationally accepted from the group. We had 38 total abstracts which were accepted at conferences, and we had 4 publications out of this. And they are all naive clinicians who learned research with their day-to-day practice by barely sparing 5-8 minutes in collecting the data. So if they can do it, I can do it, so can you. So I'm sure all of us today should start with this workshop, which is the first step towards becoming not only a good clinician, but also a good researcher. Thank you so much for being here. Thank you. With this, I would like to call Dr. Rakesh Padade to come and introduce Dr. Supe for the first talk.
It is like, I am asking, madam is asking me to introduce the God himself of medicine. We know sir since I was a resident at Nair, since then I know sir. Sir was dean at, I think, except for Nair, all the institutes. And sir was director at KEM. He retired as director. Currently he is he's director of Hinduja Hospital, and he has profound knowledge about clinical research. He has published so many papers, the count is too big. I am ashamed to even say, because we are nowhere near his publication count. And without wasting any time, I would call Avinash Supe sir to give his talk on the said topic. Thank you, sir.
Thank you. Thank you so much. I think thank you so much for inviting me. There are so many big editors here, so many experts. I am still trying to, I asked Nithya actually what I'm going to teach you about research. So she only has taught me so many things in my life. So I think you should realize that this is more of my thoughts which I'm going to share with you. And I think I was amazed with the whole idea of sugar research. Somewhere about 10, 12 years ago, I'm a surgeon, so you understand my knowledge of medicine and diabetes. So once I went to the medical education conference in South Africa, and there was one topic called sugar workshop. So I was really amazed. I said, what is the sugar workshop? This can't be diabetes. So I went there. And actually it was a 3 hours workshop when they really told us the whole story of sugar research. And I said how the sugar industry deviated the whole research and how and I'm sure I wrote about it in one of these 1 month ago in Lokmat, about how the sugar research has been completely gone through over the last 30 years. So I think it's very interesting for a clinician to understand what a research is and how do we really go into this whole world of research. It is amazing. So I would like to thank Nithya, Rakesh, the whole team. Now the clinician's question is always there. My patients don't ask me how many publications I have, how many citations I have. This is a question which is asked by many clinicians. I have a huge practice. I have 100 patients waiting every day. They don't ask me how many publications you have, what is my H index and I index, which is anyway becoming obsolete now. H index and all is becoming obsolete now. People are talking about impacts. So why should know about our research? That's the first question. Many of our people in our centenary group really put it this in our, so I was amazed. So clinical excellence today means sound diagnostic skills, technical competence and compassionate patient care. If you really look at, these are the three: cognitive, technical and affective. These are the three skills if you have today, basically you can do a practice. Many times today even you don't know, so much of knowledge is not there, it is not necessary. You have a mobile, you have ChatGPT, knowledge is not necessary. What you really need is a good, compassionate patient care, empathetic skills, good amount of technical skills where you will not harm the patient. I think you can do a good practice. But today what we really need is a research literacy. In the changing world, in a dynamic world where the things are changing so fast, we need to have a research literacy. What do you mean by that? Are you giving best available or possible care to your patient? This is the first question you should ask. That modern medicine evolves with such a pace, every month we are seeing a change. New drugs, especially in diabetes, are coming. It has completely changed the whole market. Are we really giving that? And it is we don't know what we used to giving it. It may not be the best available treatment. So are we ready to really treat that? So why should practicing clinician know about research? This is the first question you should really ask. So clinical experience tells us what happened yesterday. Research helps us to decide what we should do tomorrow. That's the basic difference. See, clinician is a knowledge, he really uses knowledge. He is a user of knowledge, while researcher is a creator of a knowledge. What I used to really say is that the clinician is a consumer of the knowledge, while researcher is a creator of the knowledge. So that's the difference. So how do you convert yourself from a clinician to research aware clinician? And then you convert yourself to be a clinician researcher. That's the progress you need to really do in your life. So medicine is evolving rapidly, help clinicians stay updated. Research improves patient outcomes and safety, no doubt about it. I'll give you a few examples. And clinical decision must be evidence-based today. In today's world, people, whatever you say, patients will go and Google it. They will go in AI Google and they'll come out with saying that, doctor, can I not try this? And if you write something which is not evidence-based, I think people are going to ask you questions. Maybe not all will ask, some of them may be your fans, but some of who are not your fans, some of them coming for the first time are going to ask you these questions. And of course, transforms experience into evidence-based information practice. Most important, it makes you a lifelong learner and professional growth. Unfortunately, when you achieve everything what you want in a practice, whether it's a car, house, reputation, sometimes you stop learning more. Now that's the stage you should push yourself into a research. So research is not a luxury for clinicians, it is a necessity for quality patient care. I think this is something which I would like to emphasize. This is no way luxury today. Everybody has to learn research, basic understanding of it. And why? I think practice-based medicine came into all of us, evidence-based. Initially it came with evidence-based, with a lot of ifs and buts. Sometimes evidence in the West doesn't apply to us, contextual differences are there. Sometimes what they talk about in the West doesn't suit to us. So Indian guidelines came, you are all so many Indian guidelines, Japi guidelines, so many are there. Now that also many times do not fit into all over the world. They do not fit into all patients. So we need to understand what fits and what does not fit with the patient. Avoid reliance on tradition or anecdotal experience. Choose intervention supported by scientific evidence. And of course it improves. Now, what is the impact of this in a clinical practice? Look at so many old practices were there. I am not going to go through everything, but I started operating patients for peptic ulcer surgery in 1979 when I was an intern. And today I think I probably have not operated patient for peptic ulcer for almost about 30 years. This is a very simple example. Look at axillary clearance, now sentinel biopsy. Every appendicitis surgery now, many patients go on antibiotics and they get well. So I think rectal cancer, major change, small rectal cancers, now we believe in wait and watch policy after radiation. So that means complete change which has happened, and we need to understand that is the impact. So good evidence changes good practice. So people, that not every paper will change practice, but a good evidence which is proved will change the practice. Good practice will initiate minds of people. Good publication will initiate minds of people. But ultimately a good evidence will change practice. So most important is keep up with advances in medicine. Medicine is a complex science. It's not a simple science like physics. Of course, physics also is changing. But here, if we don't keep up with advances, and how many of you are able to keep up with every day? Today AI has come. ChatGPT has come, you can summarize every paper. Today in fact, many of our students will go on ChatGPT and ask what is the gap in the research, what is the new thing. Some of these are done, 83-90% people, students use ChatGPT now. So medical knowledge doubles rapidly every 73 days. Now it's coming down to 50 days. I cannot cope up with so many papers coming every day. New drugs, new devices, procedure images, clinicians must adopt. So type 2 diabetes, it's my wrong to talk to you with type 2 diabetes, you are so experts in all this. But if you really see traditional therapy, and now these GLP-1 agonists have come, it has changed the whole world of diabetes, obesity, obesity surgery, to be very frank. Once upon a time was so done proficiently, now it has come to half. And that also because of traditionalists. I mean, if you ask 90% people will first try GLP-1 agonist. So yesterday's innovation becomes today's standard care, and that is where you have to really start improving the patient outcomes. Now research is something which I always feel improves some patients' outcomes. This is very important. If you read some paper somewhere, you read some case report, many times you used to see what is importance of case reports. And I think Nadkar is there, Jappi reports, both of you are there. So if you see what is the important, remember sometimes you read a case report and you remember it after many years and you go back and you say, okay, this was done. You try it many times, the patient gets well. That is most important. For example, enhanced recovery after surgery. This has completely changed. I must tell you this story of cholecystectomy. When I was a resident, we used to keep after cholecystectomy 5 days of Riles tube, 5 days of IV and antibiotics, so many. In 1982, 83. Somewhere in 85, there was one fellow, Bengmark came, Stig Megbach, he was from Sweden, and he said, we remove Riles, we don't put Riles tube, we make patient eat on the next day. It was a challenging to the whole India. And since then, laparoscopy came. And today I think we start feeding patient in the evening at 4 o'clock. And we make them go home either in the night or next day morning. So this has completely changed because of the literature. If the literature was not there, I think, and the evidence was not there, we would have allowed patients to be there for 5 days, 7 days and all that. I mean, such a thing. Now, this was a very classic case. This was published recently. We had one immunocompromised patient diagnosed as duodenal obstructions. He was posted for surgery. And then suddenly get an idea, is this patient second opinion having strongyloids, treated with drugs and no surgery? Because I remember during Dr. S.R. Naik's day, we had few cases of strongyloids which we have published as case reports. So one knowledge of this particular thing can change complete patient's outcome. And this is what we need to really think. Now, most important about research you should understand is tailoring the treatment to diverse populations. We see in OPD 200 patients and we have one paper which gives standard therapy. It never happens that I give standard therapy to everyone. I continue to slightly make a change and make it little more patient specific. Now that is the best part of the practice. And if you know the basic research foundation, the changes are much better. Precision medicine, the whole world of precision medicine is evolving from what was the standardized NCCN guidelines Now we are going to the precision medicine guideline. Your chemotherapy changes, your radiotherapy changes, your whole genetic manipulation changes. Now today, there are so many labs which are giving you genetic mapping. So many are trying to tell you. Bias, of course, there is a bias and socio-economic considerations. We still are based on the westernized data. We need to develop our own data, and therefore research groups like this is such a, if we don't put our own data, who is else going to guide us? And that's the importance of this data. Why we need to our own data? Maybe we say, oh, what I'm going to bring, don't bother about it, publish it, I'll show you so many examples where a paper from KEM, which everybody would thought is not there, have got more than say 700 kind of citations. So it is a very common thing. I mean, you don't have to worry. Research converts better processes into better outcomes. You should not really worry. Now, critically appraise medical literature. This is a side effect of going into the research, but it is one of the most important side effect. If you learn to look at a paper carefully, then you understand what is done in this whole, world of literature and world of publication is also, there are so many problems and biases with that. It's not all clean. So if somebody is trying, there is a bias, people want to push some medicine, something, all this kind of thing. So how do you really look at it? How do I critically know what is good and what is bad? And not all published studies are reliable. That's the first question you should remember. Need to identify bias. Now, for example, the classical example was new cancer drug therapies, which claims increased survival, small sample size. To give an example, classic paper from New England Medical Journal. Standard paper, sorafenib in advanced hepatocellular carcinoma, sometime came in 2008, and it's supposed to be a drug, very costly. You put it. Little go into details of this drug. It was significantly improved overall survival. Hazard ratio was 0.69. P value significant. Sorafenib should be considered as a standard therapy. Many clinicians stop here. They don't read beyond the conclusion and the kind of an abstract. Their interpretation becomes excellent drug. It reduces mortality by 31%. That is the conclusion. And this is actually an incorrect interpretation. Little go more detail. Hazard ratio is not absolute benefit. It is many patients live 31% longer. Hazard ratio simply means patient receiving sorafenib have 31% lower risk of dying at any given point, and not the survival increase by 31%. And if you really look, median survival increased from 7.9 months to 10.7 months, which is hardly 1 or 2 months, and with so much of cost. And we don't know the quality of life of those 2 months extra. And if you don't understand this into proper perspective, you are losing of that whole treatment. So whenever you are looking at a kind of a publication, your research agenda is of a great help. So the study included so many child A patients, and many real patients have child B, C. So I think these kind of studies, even if it's published in NEGM, this was criticized so much. And if you really see, they have teaching message. The paper illustrates several common pitfalls reading clinical risk. And if you really see the recent trial, Reflect trial in 2018, this came in Lancet, lenalidomide versus sorafenib. I can go on like this n number of times, and so many papers I can show you where there are flaws, and whether it's a medicine or surgery, and you have to really look at them very carefully when you apply that. See, patient is mine. I am going to do it. I am going to do surgery. I am accountable for everything. I have to face relatives. And why should I really blindly believe this? So unless I have a research, I am not going to critically evaluate it. Because see, I am taking responsibility. Every publication is not evidence. None participate in a quality improvement. See, ultimately we are all now today talking about quality improvement in patient care. We have achieved a standard of care. We have seen patients. Now we see how I am going to improve my care. So give you an example, surgical site infection audits. This is a very classical kind of a thing. Today antibiotic resistance is so much, no new antibiotics are coming. So what is in our hands? It is our hands is see my results, see my audit, see my governance, and how I can really improve, for which you need a research kind of thing. High infection rates identified, antibiotic timings corrected. Data driven improvement begins with clinical inquiry. So you have to ask first question, my infection rate is so high as compared to other hospitals. If the standard rate is 2%, why my infection rate is 4%? And then you go into details of that auditing, you will probably get, Personalized patient care, I talked about it, recent, like say, so many research supports anticoagulation, frail elderly patients with fall risk. Evidence guides clinicians individualize. Remember this. You have a broad paper, but ultimately when you apply it to a particular patient, you have to individualize. Durable disease control following multimodal therapy. Now, most important is enhances your professional development. I think I was so happy with your example, I used to also feel, okay, my biodata and all used to feel. And see, sometimes I used to feel, no, now after a particular stage, this has no value, I must tell you. After that p-value and publications and citations, it has not much of value. But for a particular period of time, you feel happy. Today, many times you find you go to interviews, they ask your H-index, they ask your impact factor, citations, if you want to get awards and all that is asked. But up to some level, you have to develop yourself. At least you should have 2-3 nice papers, and every academician should have one randomized controlled trial. That's what I feel. I feel what you should do, every clinician should have one paper publication. Maybe it's a case report, and every professor or academician should have one randomized controlled trial. That is what I always feel. If you have not done a good randomized controlled trial and published it, I think that academician is thoda deficient hai. So you develop a critical thinking, you foster academic growth, and hernia surgery outcome research, I think sometimes, surgeons analyze their own results. I must tell you, some of my residents went to France to learn laparoscopic surgery in 90s, and they came back and they say, sir, we want to do hernia surgery, this Stopa's repair. I said, okay, let's do it. We published about 30 cases, that was quoted into the Mastery of Surgery. Mastery of Surgery, it was quoted. I was so impressed. This was my first thesis in my 1983, my thesis of betadine, which was quoted. I presented that paper, but most important, it was quoted in the Goodman and Gilman's textbook of pharmacology. So, as a resident, you can publish it and you can do this. So I feel that time I got little happy also, but now I feel everybody can be easily done. Stopa's repair we published into the Mastery of Surgery. Now, research transforms clinician into clinical leaders. How do you convert yourself to the leadership? You become a clinician, you become a researcher. How do you become a leader? I want to lead. People should say, okay, I will follow the policy which either Dr. Amol or Dr. They tried. So, clinical practice generates important questions. Everyday observations can become your research. And this is, I would like to give this. Sometimes we see something and that becomes a research. Our advanced profession. COVID-19 was a classic example. I think Milind was also in our committee. Clinicians reported unusual presentations, shared treatment experiences. I'll give you one example, very interesting example. Today you have put this muscle health and strength, I'll give an example, simple example. 2007, we had a new department and we used to do a lot of laparoscopic surgeries every day. And suddenly I started getting a severe shoulder pain and back pain. And I went to, that time there was no literature, nothing. So I went to orthopedic surgeons. Orthopedic surgeons, Avinash, X-ray nikalo, X-ray mein kuch nahi hai. Tera wo paracetamol, ibuprofen, substandard de diya. Pain did not go. So I said, what is the problem? Ultimately, shoulder pain, I went to physiotherapist. That time we had a physiotherapist, Bhavna, and we had a wonderful physiotherapy in Maria and all. They said, sir, this is because of, they came to my OT. They saw all this. They said, sir, this is because you are holding a laparoscopy like this, your shoulder and muscles are getting. So I went into little detail. There was no paper except for some reference. So I did a lot of work on this and I put my first, at that time we used to use TheraBand. And I published my first, and I went into the water sports, how they use it, how people use expansion. If you see, though Kerala boats and all know how they really do it. So, movements are never like this. They are always like this. They never hyper abduct their shoulder. So, I went into details of this, and we published our and safety instructions. And then I published my first paper on ergonomics in laparoscopic surgery. It was the first publication in the literature, in the new literature that time, except for few references. And then I gave many talks, and it has cited more than 250 times. And I think if you really see, it opened up now every conference, every course has a ergonomics as a topic. And people have realized the value of ergonomics and physiotherapy, TheraBands, how do you strengthen your muscles. Now the question is, I suffered, therefore I did it. I should be able to do it without suffering. And that is a clinician's kind of an point. So I personally feel we should be able to more vigilant on the deviations which happen. And every patient encounter is a potential research opportunity. And that's what we need to really think. Sometimes in OPDs we don't have time, and we have 200 patients and we see them like factory. But if it's an odd patient, spend time. Doesn't matter, patients will wait. But if you want to spend 10-15 minutes, even in your busy OPD, spend more time. Try to go little, try to stimulate your brain. That's such a great energy for your brain. Patients are increasingly informed, shared decision making. I don't want to go robotic surgery. Patient asks if robotic surgery is better. This is a very classical thing. I'm asking patient to robotic. I should be able to know the research behind robotic surgery when I'm advancing a patient. There should not be only commercial kind of an angle. I should have a scientific angle for which I should know why I'm doing it. So research literacy improves patient conversations and transparency. You can tell patient, this is what is good, this is what is not good. Let me tell you, your patients will start respecting you much better. I mean, many of you are not surgeons, but I'll tell you, I'm a surgeon. So if I'm going to do something which is aggressive, for taking patients, taking one extra tablet, they won't bother. But if somebody has to undergo robotic major surgery, they'll ask 3-4 people. Second opinion is now common. So that time you have to be better research evidence based and transformacy based. So lastly, I think meet ethical and professional responsibilities. You have to understand ethical and antibiotic prophylaxis practices, how we now convert from 5 days to 1 day, and we don't want to create the community kind of an resistance. And so providing evidence-based care is an ethical obligation. We today cannot give them 15. So a research-aware clinician, I want to create a term called research-aware clinician. I want you to convert yourself from a clinician to research-aware clinician and slowly into a clinician researcher. I don't want you to be purely researcher. I think I don't want you to do that. Be a clinician, be a good clinician and be good researcher, but at least first convert yourself into a research-aware clinician. Ask questions, seek evidence. Only 2 things. First sentence in our college was, here you are not to answer questions, but to question all answers. Be inquisitive. That's the first question. Critically appraise literature. Applies findings appropriately. Measure outcomes. Look at your own results. Sometimes, keeping data like this. Today, it is so easy to do it with voice AI, Suno AI, with various kinds of HMIS at clinic and OPD level. All these AI is coming up. Analyzing your own results is not very difficult, and it is available in practically clinic at an affordable cost. Shares knowledge. What is the difference between a good clinician and academic leader? I think if you really see, good clinician is a consumer of knowledge, while academic leader is a generator of knowledge. Shift yourself from consumer to generator, consumer to entrepreneur, I won't call it, but to this, that. And of course, problem solving in a clinical certainty to problem solving with ambiguity and in ambiguity. I think today what has happened, problems have become more complex. So it's not simple problems we get. Out of 10 patients in an OPD, hardly 1 or 2 are simple problems. 9 or 8 are difficult problems. So we have to find out contextual solutions for those complex problems. So we need to think. Research is not about making every clinician a scientist. It is about making every clinician a better doctor. So understanding research does not imply that every clinician must a full-time investigator. Rather, it enables practitioners to critically interpret evidence, apply it appropriately, and continuously improve patient outcomes. So that is the first goal. And every patient encounters raises a question, research helps us find the answer. Whenever I have found a difficult patient, today also I go in the literature, before doing a complex operation, I see many videos, I see many evidences, and I think that is before you is the way you improve your practice. So finally, the clinician of future will not be judged merely on technical skills or years of experience, but ability to ask right questions, critically evaluate evidence, and translate that evidence into compassionate, individualized patient care. Remember, these words are so important. Convert your research into compassionate, individualized patient care. And research is not separate from clinical practice, it is the foundation upon which better clinical practice is built. See, a patient comes to you after 30 years and he tells you, डॉक्टर साहब मैं आपके पास 30 years आए थे, आपने वो दवा दिया था, मैं उससे ठीक हो गया और आपने मुझे बहुत अच्छा ट्रीट किया था. He remembers only two things. How you treated him, so that becomes compassionate, and he also tells you that how I individualize. He doesn't remember the medicine drug at all. He doesn't remember what we have given him, but he remembers the way you treated him and the way you individualize his care, and that matters most in this particular field. So thank you so much, and I'm sure I can take some questions. I hope I'm in time.
Yes.
Sure. If you want, I can take one or two questions.
If there are any questions from the audience, please come ahead and feel free to ask questions to sir. Yes, sir, please.
This is not a question. I would request everybody to give sir a standing ovation. There was an outstanding presentation. Amazing.
Thank you.
Every point that you have made, sir, are a pearl of the wisdom. Absolutely. And let me have with Milind around and our chairman around. Let me tell you that we are launching our first journal probably at December. Please have a seat, please. So, Mahajapi. So, now the sir, I'm going to extract this opportunity without your permission, but I would request Nithya madam and you to write down a first editorial of Mahajapi. I would request you.
Sure.
Simply amazing. I'm really blown away. Beautifully illustrated.
Definitely. Yeah. Thank you so much. Any other questions, queries? Yes, sure.
Can you please come ahead because we are live also.
It was an absolute honor, pleasure and privilege. I just wanted to say something. Compassion. You mentioned compassion again and again, and that's, I think, what we need. Empathy. What is empathy? E for engage with the patient. M for mindfully listen. P for perceive his or her emotions. A for acknowledge. T for translate. H for honor. And Y for yielding results. That's empathy for me. Thank you, sir.
Thank you so much. Amol, you want to ask anything? Sure. Thank you so much.
Sir, before you go, sir, we would like to felicitate you with a small token of appreciation. I would like to call Dr. Nikhil Baglanke, sir, to come ahead and felicitate Dr. Supe, sir, for that excellent talk. Dr. Balanke, sir, is our chairman of Maharashtra API chapter. It is indeed very important for all of us as treating clinicians to make note of small observations that we have in our day-to-day OPD, and probably, as sir rightly said, we should read about it and we should think about some research questions that probably we can contemplate and take it forward. Now, taking this discussion forward, I would like to call upon stage Dr. Nithya Gogtey, madam, who is HOD of Pharmacological Department in KEM Hospital, for our next research topic, that is how to formulate a research question. Please welcome, madam. Dais is yours.
Good morning, everybody. And at the outset, my sincere gratitude to Dr. Milind Natkar, sir. I remember we had this conversation in the Dean's office 3 months or 4 months ago about this workshop, and Rakesh and Madam and everybody else, Dr. Tivaskar, for having all of us here. Let me start with a publication, 1999, that was in the British Medical Journal. This was an early clinical research study. In the late 18th century, King Gustav III of Sweden decided that coffee was poison, and he ordered a clinical trial. The king condemned a convicted murderer to drink coffee every day. Is it moving, or if somebody can move it for me? It works?
Use green.
So there are 2 greens. Yeah, this one, no? Yeah, yeah. All right. Chalat nahi. Chalat nahi the. If you can either get the laptop here, or you can just move the slides, whichever. I think it's low battery. So for those of you who believe in astrology, no, Mercury is retrograde, right? So your travel, your speeches, everything get affected. So I was wondering what would happen today. It has happened. Now everything will go well after this. Is this the one? All right, perfect. So the control was another murderer who was condemned to drink tea every day. The outcome of interest was death, and 2 physicians were appointed to determine the outcome. So if you look at the results of the study, the 2 doctors, they died first, yeah. The king was murdered. Both convicts enjoyed a long life. The tea drinker died at the age of 83, and the coffee drinker, we don't know when he died, right? So what was the conclusion of this study? The conclusion was that the p-value was greater than 0.055%. External events and biases were possibly confounding the whole study. So, and this is true, coffee was forbidden in Sweden in 1794 and yet again in 1822. And it was decided that kings should not mess with research questions, and they should attend these demystifying research workshops. So what I will do over the next maybe 30 or 35 minutes is talk to you about formulating a research question. How do you actually do it? We first start with what is a research question. So it's essentially an uncertainty about a health matter, something that you're trying to answer or resolve. And I think this is very, very important. Well-crafted research questions guide the systematic planning of research, and formulating your questions precisely actually helps you to answer these questions. Now, I don't know if Budhan Mercury will help me with the next slide. If he doesn't, we will go forward. I have a Mentimeter quiz here. Yes, sir. So I would like all of you to scan this QR code, please. Now the question I'm asking you here on a Sunday morning, 12th of July, why are you all here, na? Kashala, why? There are 4 options. The first option is not sure. Hopefully the lunch here is good. We had tari poha in the morning. The second option is I didn't feel like meeting my in-laws. So the workshop is, The third is I actually going to try and learn something. And some of you are scared of the organizers. Answer truthfully, yeah? Answer truthfully. Scared of, then answer, no. See, the advantage is nobody will know who is answering what, na.
People are scared, that much scared, they're not answering.
They're not, just they're so scared of the organizers that they're not answering. All right. Okay. Okay, now how many of you all are watching FIFA 2026? Yeah? Wimbledon? Very good. Now you answer the next question. And don't look at ChatGPT, huh? You will really get very angry. These are shoe manufacturers: Nike, Reebok, Adidas, and Puma. I'll tell you why I'm asking this question in a bit. Which of this is actually a Greek goddess? It came in the KBC also. Don't Google, don't ask ChatGPT. Be sincere. You should not write Puma, no? It's that Jaguar, no? Actually, you... No, sir, I'm just saying because I remembered that. I mean, I only made this question, but... Sorry? It's a different, that's why, I remembered that, yeah, so the answer is Nike. Somebody has Googled. Answer is Nike. Nike is actually a Greek goddess that is associated with speed, strength, endurance, yeah. So Nike is actually a Greek goddess. It doesn't sound like, but it is. So what is my question here? Why did I ask you that question? So the first thing I think in research is, now I will start the topic, the jokes are over. You have to be alert to new ideas. Now, who is this? Alexander Fleming. Yeah. So in 1928, Alexander Fleming left a culture open on a windowsill. He went on a holiday. He came back and he found growth. So that was Penicillium notatum. And he synthesized penicillin. What is very important is what Dr. Supe said in his presentation. He published the paper. Nobody bothered about the paper. And he also started doing something else. In 1938, when we had the Second World War, this was taken up by Florey and Chain, and they were able to treat a lot of soldiers and save a lot of lives. So the Nobel Prize was first given to Florey and Chain. So this man said, "Arey mera kya, maine hi banaya tha pehle." So that's how it was a Nobel Prize that was shared between 3 researchers. How many of you have been to London? If you have, you may have seen this, yeah. So this is the window, no? I put that blue arrow. That's you've seen that, sir? Yeah. So the exact window where Fleming left the culture, and this is Sir Alexander Fleming, 1881 to 1955. So what was his research question? Can the mold which killed the staphylococci in culture be used to treat patients with staphylococcal infections? And for one thing, I think, and this is again what Sir ended with, have a prepared mind. Every patient encounter offers you an opportunity for research, right? So, and this is again Albert Einstein's quote, "It's not that I'm so smart, it's just that I stay with my problems longer." Now, this answer I have given you. This is Selman Waksman. No bells are ringing, no? Good. He was a discoverer of streptomycin. Yeah. So, tubercle bacilli are destroyed in soil. Actinomycetes are present in soil, right? So can I find an organism, can I find an antibiotic in the soil which actually destroys these tubercle bacilli? And he was actually energized by the discovery of penicillin, or the use of penicillin in World War a few years ago. And then he isolated streptomycin in 1944 and was awarded the Nobel Prize in Medicine or Physiology in 1952. So what was his research question? Can I find organisms, can I find antibiotics from the soil? So what he did was essentially, you can draw inspiration from other researchers. I think the average age in the room, I think we're all past the age where we'll get any Nobel Prize. the cutoff age is about 32. If you read that book by Watson and Crick, the cutoff is after that you're not going to do anything in life, in research, not in life, sorry. So you have to exploit similar ideas rather than embarking in new ones. This is my favorite slide, not because I published anything, but because as Indians we are very good at this, copy and paste. Best is to reproduce what somebody has already done. And having said that, I'm not saying this sarcastically, but you have to reproduce something in the Indian context as well to see whether we are similar to or different from somebody who's done the work elsewhere in the world. So this was done by a teacher of mine, Dr. Adityan sir, study of polymorphisms of CYP2C19. It is an enzyme in the liver that metabolizes omeprazole, right? And he classified South Indians into extensive metabolizers and poor metabolizers. So we did the same thing in Mumbai and we asked 2 questions. Who is an Indian? Are we the same? And are Maharashtrians and Gujaratis in Bombay similar to the South Indians? And we found that our answer was the same as Dr. Adityan's answer, which is about 14% were poor metabolizers, and they may need a different dose of omeprazole. The other thing which we can do, I think which is very special and unique for us, is to work on diseases that matter to us, right? So this was my PhD thesis. I started doing my work in 1991 or 92. At that time, the Brihan Mumbai Municipal Corporation, the BMC, used to give 5-day Primaquine for Plasmodium vivax. All of us today give 14 days Primaquine as per the WHO protocol. So this was a 5-day regimen which was actually initiated by some Dr. Roy, and the publication was in 1977. So I did serve my first randomized control trial, where we divided patients into 2 groups. The first group received 5 days of Primaquine. The second group received 14 days of Primaquine, and we found that there was a significant reduction in the efficacy of Primaquine in the 5-day group. So it was only 83%, and this eventually changed policy for the BMC. So this is important when we do studies which are relevant to us, right? And they can contribute to policy decisions. I think one thing that not many people are capable of, I think at least I am not, is the ability to challenge dogma. Sir had mentioned peptic ulcer surgery in his presentation, and this is Sir Barry Marshall Robin Warren. Some of you will know the story of the discovery of H. pylori, right? So he actually drank the broth, then he vomited, he had a biopsy and he grew H. pylori, okay? And why did he do all of this? For years, an obscure doctor hailing from Australia's West Coast watched in horror as peptic ulcer patients fell ill, and many of them had their stomachs. This was before the advent of omeprazole and the other drugs. Then he found this corkscrew-shaped bacteria. Just go back here. Yeah, corkscrew-shaped bacteria, which he termed as, they used to be called Campylobacter pylori. Now it is Helicobacter pylori, right? Now what happened, just like Fleming left his petri dish on the windowsill, this fellow left his petri dish, and it was on Thursday. And that's why I always feel religion is also very important to formulate a research question. So Friday ka Easter ho gaya, फिर Saturday ho gaya, Sunday ho gaya, you come on Monday morning. Because when we used to do at that time for 48 hours, it's a very slow growing organism. So you don't culture it very fast. And because it was Easter Friday, and I also read a very nice website on Nobel laureates, read it. He was not allowed into the lab to check his culture because the dean had said, nahi jaane ka. So Monday when he came, so the dean and the religion that he practiced did a favor. So he actually grew these bacteria. Now the next thing, which is very important, is not to be, don't feel dejected, if something goes wrong or your paper is not accepted or something. See, look at this. This is for Dr. Marshall. I regret that your research paper was not accepted for presentation in the annual scientific meeting of the Gastroenterological Society of Australia. So what did he do? He just drank the broth, Yeah. So what he did was he adhered to Koch's postulates. Therefore, he grew the same organism. And this is again from the Nobel laureates website. That Marshall and Warren's achievement is made more extraordinary by the fact that they perform their work not in well-endowed, cloistered medical institutes, but in the orderly chaos of a municipal hospital or whatever hospital that he was working in. I don't need a Mentimeter to ask you how many of your practices are chaotic. Everybody's practice is chaotic. This fellow's is not. Okay. Right? And then I've said this before, but you also need to identify an area of importance to your own country. And I would like to acknowledge here my mentor, Dr. Dilip Karnad, who's taught me a lot of statistics and so much more when I was with Sir in KEM. So what Sir did was, he looked at the quality, cost and outcome of intensive care in a public hospital using Apache 2 and the TISS course. And what he did was, he studied almost 1,000 ICU patients over a period of 1.5 years. And he found that although ICU care was cheaper in India, there was much higher mortality, almost twice, because of the lower nurse to patient ratio and the higher workload per nurse. And the Apache 2 score may actually underestimate mortality for Indian patients, right? So you need to figure out something which is close to your heart, which is also relevant to the country. And what I would like to say here is that this is the structure of the benzene ring, right? Everybody always thought benzene ring was like two-dimensional, flat. Okay? And nobody knew what to do about the structure. They couldn't go forward, right? Until this fellow Kekulé, Frederick Kekulé, he was sitting in his armchair in front of the fire and he started dreaming in his REM. And then he saw a serpent coiling on itself, right? That's when he realized that the structure of the benzene ring was actually not two-dimensional, it was actually three-dimensional. So the idea is to keep at it, persist at it, and always let your imagination, lead your way forward. So, and this is again from Albert Einstein. This, I think, is one of my favorite quotes. The intellect, we think we are intellectuals, we are so smart, has very little to do on the road to discovery. You need a leap in your consciousness, right? Something that tells you this is what it is. You call it intuition, you call it whatever you will. The solution comes to you. You just don't know how and you just don't know why. But you find the solution. So all of us have it within us without needing ChatGPT. Yeah? All right. Now I will spend the next 10 minutes or so focusing on what are the characteristics of a good research question. I've told you the multiple ways in which you can formulate research questions. The easiest is, of course, what your patient teaches you. The second easiest is what somebody else has already done. A good research question should be feasible, interesting, novel, ethical, relevant. So these are called as the finer criteria for formulating a good research questions. So let me just talk about a feasible research question. And here again, I would like to acknowledge Dr. Nilimak Shirsagar, my guide, PG teacher, with whom I did this work. And Madam had got a lot of money from WHO for doing a cluster randomized trial. One village, we gave diethyl carbamazine plus albendazole. And the other village, we gave only diethyl carbamazine, and we were looking at the macrophyllericidal activity of albendazole and microphyllericidal activity of diethyl carbamazine. Now, because it was a WHO funded project, they also wanted to see, was there any drug interaction between DEC and albendazole. So we had to collect blood samples also from the villagers. Okay, so one day went. Next day, so we used to get up at 4 in the morning, sit in that tracks, the jeep, and go there. And there was a small bridge which we had to cross before we entered the village. Now, Madam was there with us for one day. Next day, there was a resident strike. So madam said, आता मी मुंबईला परत जाते. So who is the boss? I am the boss. And how old I am? 27 years old. मी पुढे बसले ड्रायव्हर बरोबर. I sat with the driver. ऐसा बॉसगिरी करके जाने का होता. So I went. Then once you reach that village and we were about to cross the bridge, there's a typical Lagan type of scene over there. Yeah. So you had men with lathis standing over there, and they would not allow us inside. So I got down. You have no idea how afraid I was. I stood on this side only. I didn't cross that side. They said you can't come inside and work. So we went back to Sevagram, where we were doing the work with the community medicine department, Dr. Garg, and then he talked to the village person, and then finally we started the study. Eventually everything was sorted. What was the difficulty? When we collected blood, the men in that village felt that by collecting blood, they would not be able to perform. So they linked it with impotency and loss of virility. So the one thing that this thing taught me was that when you sit in the World Health Organization in an air-conditioned office without you touching base with reality, pharmacokinetics, these projects don't work. You need to know what is happening on the ground. Hence, I think one of the most important things about a research question, is it feasible? Is it doable? Given the environment that you work in, given the circumstances that you are in, are you still able to carry out the research question? Therefore, I think the best research in results came in COVID-19 from England. They had the simplest research questions. Do inhaled steroids work in COVID-19? Finished. One objective, one outcome. Finished. So this is it. I think it makes a lot of practical sense. Research questions by default should also be interesting. Yeah, logical step in your career. Financial support you get, definitely. Yeah, and I would like to thank USC for funding us to be here. But most important is you need to get to the truth of the matter, and I think that is why you need to do research. There should also be novelty in what you do, to the extent possible. I've already said you can copy paste, but it should still be novel for the population that you are working with, right? And I'll spend one slide on ethics, yeah. And Dr. Gadgil here will speak to you on the importance of ethics. This was again a randomized clinical trial which we did. This was in the mid-1990s. Yeah, so we had two groups of patients. What you use today, artemisinin derivatives, they were discovered, known as Qinghasu, discovered in China. There were a lot of chota studies which were done, which did not show superiority over quinine or chloroquine, did not show superiority. Going back, we realized they were underpowered studies, but so we did a randomized control study, and Mumbai was dealing with multi-drug resistant falciparum malaria at that time, 1995 I'm talking about. So we sent the protocol to the Drugs Controller of India. The resistance to chloroquine at that time was 5%, right? And the protocol approval came after 3.5 years. I'm talking about 1990s, I'm not talking about today. So this was a 40-year-old male patient. This was in Kasturba Hospital under Dr. Jahangir Sorabji. He consented to participate in the clinical trial. Double-blind, patient improved. On the last day, day 6, he died of acute respiratory distress syndrome. So we broke open the code and we found that the patient had received chloroquine. Right? We analyzed it and we found that in the 3.5 years that we were waiting, the chloroquine resistance had gone up from 5% to almost 25%. So we realized that chloroquine should not have been the comparator of choice in that clinical trial. Of course, we stopped the trial for utility, yeah, and now whatever you use today is actually a product of this work which we did, Ciba-Geigy, in those days. But it came at a cost, at least for that particular individual patient. And the other thing, the last R, is your study should be relevant. Finer criteria. And I gave you the example already of the 5-day primaquine therapy for Vivax malaria and contribution to the BMC's policy of using 14 days primaquine. Another thing about research questions is try and make the focus of your research question as narrow as possible. It gives you an easier opportunity to answer the research question. So let's say we work in the field of adverse drug reactions, medicine safety, pharmacovigilance. This is the topic that you're interested in looking at, adverse drug reactions. Then you say, I work in a tertiary referral center, so let me look at patients who come with adverse drug reactions to the hospital. Then I say that is also too much. Let me just focus on the EMS part. So then I see patients who come to the EMS with adverse drug reactions, and you find that that is also too much. So what do? I say all those EMS patients who get admitted, I will only focus with them. So you start with something broad, but eventually your chance of answering the research question will be much easier if you are able to narrow down the focus of your research question, right? And you could have something called as a primary research question and a secondary research question. Primary is out of 100 patients, 5 patients get admitted. That is your answer. In those 5 patients, what is the cost to KEM hospital? What is the economic burden of patients who get admitted would be your secondary research question. You could have descriptive research questions and you could have analytical research questions. Descriptive, for example, what is the proportion of patients in a particular village who develop chikungunya? But an analytical question would be, what are the predictors of the risk of developing chikungunya infection? So descriptive, not a problem. Analytical, or determinants, no, those would be more like analytical questions. And the last thing that I would like to end with now is PICO. And I think this is, I would say, the take-home message from this particular lecture. Try and fit your research questions into the PICO format. What is P stands for the patient or the problem. I stands for the intervention. C stands for the control. O for outcome. And T for time. So this is your research question. In patients with type 2 diabetes, does continuous glucose monitoring compared with finger stick glucose monitoring improve HbA1c over a period of 6 months? So if you put it into the PICO format, the population is patients with type 2 diabetes, your intervention is CGM, compared with your finger stick blood glucose monitoring, outcome of interest is HbA1c, and the time frame that you do it is T, that is 6 months, right? Similarly, overweight patients with newly diagnosed diabetes, does a structured exercise program, that's why there's a physiotherapist here, compared with usual standard of care, reduce your HbA1c over 12 months. PICOT, PICOT, PICO, whatever you call it. Try and see if your research questions can go into this particular format. Now I will end, because I can see some of you sleeping, I will end and I will ask some questions now so that you all will wake up. Many of the questions are out of syllabus, no Mentimeter, you all can answer. Which of the following is not part of your research? Not. Identifying an area of research and formulating the research question, developing a clear research strategy, design and methodology, getting funding and coming up with detailed explanations for your outcome. I love group answers. Yeah, you don't generally you think already of the funder ahead of time, or maybe your study doesn't need funding. One source of ideas for research is past research. Why would somebody do research on something that somebody has already done? Too many published articles use qualitative methods, whereas you need to do an experimental method. Journals like to publish replication studies. 3, results of one study create more questions and answers. 4, technology has changed so rapidly that older studies are no longer valid. 4 or 3? It's 3, maybe 4. Today's age, maybe 4. 3 and 4, all right. Which is not a part of the research proposal? Literature review, a Gantt chart, outline of methods, and the research question. A chart showing timelines. First 6 months में ये करने का, next 6 months में वो कर. Yeah. When is a Gantt chart necessary in a research proposal? When you're actually submitting it for funding. That's the only reason. Like somebody is giving you money, you have to tell them, Baba, 3 साल में खत्म कर देंगे, right? So otherwise, it is the Gantt chart which is generally not needed in a research proposal. All right. Which of the following is not part of a research proposal? Research design and methodology, research question, a detailed discussion about the study results, and literature review. Good. Now you answer this. I think that's my last slide. You don't have to keep me happy. I said you don't have to keep me happy. I answered the question. Everyday life, practical issues, yes. Past research, yes. I didn't give you a single research idea. I answered the question. E, past research, practical issues, and everyday life. And remember that Columbus didn't get it right the first time. Yeah, this is the first globe of Columbus. And this is more when I talk to academicians, right? But I think it's relevant to everybody. What it takes to recover from a setback is actually what you do next. That's very, very important, 90%, right? Yeah, and I'll again end by quoting Albert Einstein. Never regard study as a duty, but the enviable opportunity. When you say study, no, he's talking about research. To know the liberating influence of beauty in the realm of spirit for your own personal joy. I think for me, research has brought a lot of joy. And profit of the community. So it's the community that benefits from your research, ultimately to which your work belongs. Yeah. So thank you, ladies and gentlemen, for your kind attention. Are there any quick questions?
When you try to narrow down or focus the question, generally when you are submitting your thesis on a proposal to the MHS, generally says that you should be able to write down 5 papers or 2 to 3 publications from your thesis. So,
Is that right? PhD?
yeah. Generally, if you are doing a PhD or if you are doing even the PG, the generally teachers think that you should be able to write down minimum 3 to 4 papers or few publications from your thesis angle. So it becomes sometimes difficult to narrow down your.
So let me answer your question. I understand where you're going. Now we saw Dr. Supe, no? He had published his paper that the use of povidone iodine. Yeah? That is the paper. And I think if you ask Sir, the answer will be that only one paper he got from his thesis. If you ask me, the paper that I published from my own dissertation was a single paper. It was actually a short communication or a short report in the Indian Journal of Pharmacology. The way I see it, Sir, is that thesis is for you to understand research methodology. Thesis, the paper is a byproduct of your understanding. You must publish papers. I don't think we should say 3 papers or 2 papers. A good high quality paper that comes from your dissertation, whether it is MD, MS, DM, MCH, a PhD. A PhD is more likely where you will get more than one paper because you may answer more than one question. While I said narrow the research, it is more from a feasibility point of view. You can do extensive research also, complex research as well. But the important thing, I think, for this particular audience is to understand research methodology as we are going along. The publication will automatically come. I am not familiar with this particular rule. Maybe it was made with a certain purpose. I don't know.
Just answer to what ma'am is asking, sir. universities, if you're aiming for PhD degree, sir, then many universities will mandate at least minimum 5 publications before the student faces the defense. But as ma'am said, that when it is PhD, your research question is so broad that it will have at least 2 or 3 research objectives, and then
Esoteric questions. So when I did my PhD, when Mumbai University was Bombay University at that time, the mandate was 2 papers. The mandate was 2 papers, and I think one of the reasons, because I serve on the academic committees of several hospitals, is that people just finish the thesis and put it in your file, in your drawer. It's called as the file drawer syndrome. खोलने का, देखने का, republish करने का है, वो वापस बंद कर देने का. So the idea is also to motivate you to publish your work. I think that is possibly the thinking behind publications.
Madam, my question. I'm Dr. Mukund. Here, madam. Here.
Yes, sir.
Thank you. Your presentation was excellent. I was trying to understand how difficult it is to publish a paper in an international journal like Lancet, BMJ, any international journal of repute. If you look at the papers last 5 years, 6 years, 10 years, you'll see very few Indian researchers publishing the papers. A very good example is Dr. Hemant Rao Bavaskar. He published the paper. You know how difficult it was. We all know. What I'm trying to say is, getting an Indian researcher's paper published in any international journal, first thing is the cost. Second thing is, they'll reject. And the third thing, even if you ask for the review of the paper, why you're rejecting it, they don't give reasons. So it becomes very difficult for a pure, good academic research paper to be published. How difficult have you found it in your own career? Thank you.
In my own career. So in my own career, so I actually don't like the term international. I mean, what is the meaning of international? Means when we go out of Bombay to Sri Lanka also, we are international only, no? We go to Bangladesh, Pakistan, international. So everything is international, sir. So what we are trying to say actually is that when you say international, you're looking at high impact factor journals that have an impact factor of 50 or 70, Science, Nature, NEJM, the Lancet and all. For that, no, his question is very relevant. Why should I narrow down my research topic? Here, when you have these broad, high quality, research, complex, you have genomics, you have antibodies somewhere, you have the clinical outcomes, and you have quality of life, then those kind of papers get into these journals. These papers are also multi-centric, multi-country papers. It's not that individuals like us can just get up in the morning and publish a paper. The reason I think why Dr. Bavaskar's paper made a difference is that he conducted a randomized control trial on scorpion bites in a village setting. Yeah, you have papers from Dr. Abhay Bang and Rani Bang also similarly. So I come back to my lecture, the quality of your research question, the quality of your research methodology, and how your outcomes impact the average patient will play a strong role in publication. So we have very high quality Indian journals also with very, so we must also publish our own work in our own journals, right? So this would be my, I think Dr. Supe wanted to add something. Yeah.
Don't get frustrated if your paper gets written. I'll tell you a simple story. About 2 weeks, what I call it as an OT side chats, or, sometimes we come in OT and sit down and we have ideas or something like that, or you are sitting a patient. I think if you are all clinicians, begin with a simple letter to editor in any journal. I think that's the best. You read a good paper, you have some thoughts, write 300 words, refine it and send it. I'll tell you one story in 2 minutes. 2-3 weeks ago, we were sitting and doing a lab call, and we had doing ICG all the time open. So we said, let's coin the term always on ICG while doing lab call. Okay? So this was the discussion. I immediately wrote down 300 words, and Prasad and me edited it, and we sent it to ANZ Journal of Surgery. They're so good that after 3 days, the letter was accepted. Within 1 week, we got a proof. It is on now PubMed. So I'm telling you, and what was it? It was a simple idea that we should keep ICG on while doing a laparoscopic surgery. Now see, idea is that, and I'm sure all of you get these ideas. Idea is that don't get worried ki it will not get accepted. If you write a proper, and best of you, I think you should write with a letter to editor. And if you begin with that, I'm sure then I think you learn through Nithya. See, Nithya and all are my teachers for all this. So they all will teach you how to write papers. And I'm sure you...
Next workshop, how
Yes.
to write paper.
Good to have a.
Don't get worried.
Can I
It's,
have,
and it's okay. Na?
can I have a comment on
Nahi
this?
kiya, nahi kiya, theek hai,
Can I have a
it's okay.
comment on his?
Yes, sir.
Yeah.
I think you should ask the organizers whether they are running. Yeah.
Sure.
Go ahead. Yeah.
So, to your question, actually, I'm serving as a handling editor to Nature Medicine now.
Okay.
So-
Nice.
So I can tell you that, as Nithya was talking about, you know, the basic, most of the Indian researches or papers which are, you know, actually we receive there, and one of being a handling editor there, I keep on seeing this, is this that it's again the repetitive work that actually limits our publications to the international journals. We need to understand this, and as sir has rightly said, that any novel idea can be best handled and best accepted, as Nithya was talking about, in our journal. And me, Milind, we edited JAPI for 5-6 years now. I did it for 5, Milind did it for 7, right? So, honestly speaking, high impact journals, the names are great, but they have their own challenges. I don't want to enter the nitty-gritties of those challenges. They'll be very difficult to talk on this kind of a platform. But I can tell you for sure that it's not that we have to reach that. Even we are able to reach our own community with our own, I would say, results. That would have served your purpose, honestly speaking.
Indian journals have a very good visibility.
Excellent. And
It's
if you
all about
I can
citations, no? The
Yes.
paper should be cited,
Cited.
seen by
See,
somebody.
so
So it
it's
doesn't
like
matter if it is
the
you know,
amount of the data products that we have in JAPI, if you go on the Google and
Yeah,
find it
yeah.
out, even though we do not have an impact factor, but the outreach to the clinician, especially in the Indian subcontinent of
definitely.
JAPI, is outstanding. Outstanding. I can tell you this.
Thank you, sir. Yeah.
Ma'am, there were two questions. No, one more question.
Are we running late? Yeah, we are running. Okay, later.
Madam is there.
Okay.
I think.
Thank you so much, Dr. Nithya Gogtey, madam, for that wonderful, wonderful presentation on how to formulate a research question. I would like to have a standing ovation from the audience. She has come all the way from KEM Hospital for all of us to teach us regarding the research questions, and I think she has had a fabulous presentation, taking us through and making us thinkers now along with the clinical practice. I would like to call upon stage Dr. Mangesh Tivaskar sir to felicitate Dr. Nithya madam.
Please sit, yeah.
Once again, thank you so much madam for accepting the invitation and coming all the way for us here.
In fact, this entire program schedule was made by Madam only.
Yes. So she has been quite a help for all of us. I would like to welcome all the new members who have joined us here, and I would like to ask them to join our community called as Sugar Science Research Studio. You can see the QR code here right on the screen. So by scanning this QR code, you will be able to join our research community meant for diabetes and metabolic research, if that is your area of interest. And we would love to welcome new members here. And we can see in the audience some of the existing and the founder members of our research studio, that is Dr. Seema Bagri, Dr. Ashna Patil, Dr. Mitali, Dr. Amol, Dr. Nadia, and I can see many of them who are here for this workshop supporting us and taking this initiative forward. Thank you so much for coming. With this, I would like to invite our next speaker on the stage, that is Dr. Raakhi Tripathi, for research design made simple and interactive for all of us. Please, madam, dais is yours.
Thank you, ma'am. Thank you. A very good morning to all of you. At the outset, I will really thank Nithya Madam, Nadkar sir for giving me this opportunity, and also to ICP API. API was also a textbook which I read when I was a student in third MBBS. So all credit goes to you where I stand today, and obviously my two teachers have set the ball rolling, Supe sir and Nithya madam, and we are now going to the topic of study designs. So it's taken for granted that you have got a brilliant research idea, you have also framed in your mind a research question, and now you think how you are going to get answer to that research question. The way you get that answer to the research question is all about study designs. Okay. So, study design was nothing but a framework by which study objectives are going to be met. So, based on my study objective, my research design is going to be based. That is as simple as that. Okay, obviously it is crucial to the outcome that I need to study. When we take examples, you would be more clear with this, and it determines the quality of the data. So depending on the design, how my data becomes more credible, you would get a picture of this as we go on revising the study designs. Okay, so let's revise. Remember, all these study designs were taught to us when we did biostatistics as a part of community medicine. Third MBBS, biostats, majority of us at that point of time would have bunked those lectures, but they taught us this. It's not that, this is typical classification from Park. I know even my teacher, Viju madam, is also there. I should not be saying that I bunked that time, but that's what there, it was there. Okay. No, I didn't bunk, but majority biostats, PSM. So this was always there. Good, madam, didn't hear my dialogue. Very good. Thank you, ma'am. Okay, so this were the designs, and the broad classification of the design was observational and intervention. So observation, as the word says, like as a clinician, whatever you observe, that observe could be your own clinic, observe could be the environment, observation could be even your office staff, how they are working with you. It's anything that you are observing is an observational study design. Versus an intervention. Intervention is when, as a researcher, I intervene. That intervene could either be a drug therapy, could either be a surgical procedure, could either be an exercise program. Intervene could also be my good communication skills. The way I counsel my patients, I do something different so that the outcome is different. So intervention does not mean always drug therapy. Intervention is anything the way I want to intervene. So it could be any of these modalities. Generally, you and me think that intervention always means a drug trial. No. Intervention is what I do something to my patients, something which is going to be different, something which is going to be new. Okay, so that would be an intervention. So observational studies broadly get subclassified as descriptive and analytical. And intervention, majority of them would end up doing a randomized control trial. What is this randomized control trial? We'll quickly revise in few minutes. Okay, and observational studies, as the name suggests, if you are a very good observer, it's very easy for you to do that study. So observational studies is something that you and me generally will begin our research career with, and they are something which are very easy to do. Like if you are learning to cook. Khichdi banana is the most easiest thing. Most of you will agree. You don't start learning cooking to do biryani, huh? Or upar se chicken biryani, and that is the last ekdam. You don't go to that. You start with those khichdis and making that rice, curd rice, all these simple things you start. So that is where your observational studies also matter to you. Okay, so ma'am wanted to be a faculty for the next conference. If madam manages to do very good observational studies and publish them, in 1 year madam will be faculty for the next conference that arrives in her field. Okay, let's go. So descriptive studies. You start with case report, case series, cross-sectional, launch. This is a classification. So let us go one by one. Coming to your basic you remember case report and case series, what sir and madam described to you. Remember that case report, case series is what happens in your practice. You observe something which is happening new and you report it. Remember, you don't plan a case report or a case series. Huh? If you plan a case, you never plan a case report or case series. It happened in your practice, some novel thing, something happened, and you just collect now the data and report it. But when you plan a study, then you go with that research idea, research question, research objectives, and I would then go and write a research protocol. Okay, case report, if I go back, okay, remember that over here, that your case report or case series is something which I'm doing in my routine practice. I am practicing and I detect a new ADR due to, say, azithromycin. It's not reported in literature, I find it. And I think this is because of azithromycin and I report it. So I never planned detecting an abnormal ADR. Are you getting that? Or I do a particular way of a surgery because of which the outcomes are better. And then I do some 4 or 5 cases and now I'm reporting. I didn't plan that novel way. Okay, but if I go ahead with cross-section and all, they are all my research studies where there will be a research question and there will be a research protocol which would come into place. So descriptive studies when we are doing, most of the times these are going to be single group and there is no comparison. There is no hypothesis, that means there is no assumption in that study. It is just descriptive. Like just now, if I want to study what is the audience attending this workshop, it's descriptive. How many, by virtue of age, gender I collect. I also collect you are from which specialty, which area you're practicing, what is the type of hospital, clinic, descriptive, simple descriptive. Single group, no comparison. There is no assumption that I am testing over here. So these are my simple descriptive studies that I'm doing. Objective of such studies is just to describe. Describe could be disease, phenomena, different perspectives, whatever. Okay, after this workshop, maybe sir will give you one feedback form and from there you are going to give opinions. This feedback that you are collecting and from that feedback is also a descriptive study. Provided sir had initially planned and written a research question, then it would have fitted into that descriptive study. So it fits into that. Okay, generally you would end up analyzing what is mean, proportion. Research question is also a very descriptive research question. It is not that Picot research question which Nithya madam spoke about. That C and that O and that time. It is just some patient and some outcome that you are doing. It's that whole 5 dimensions you are not going. Okay. Case report, case series is what I was talking. Single or a series of cases. Clinical features are described. Something very rare, unusual, something very novel. Remember, whenever you are venturing into research, all sir was very this on publication. Whenever you are going for a publication, there has to be something novel. There has to be that answer to the question, so what? What is new in this? That somebody will read it. अगर मैं खिचड़ी बना के आपको खिला रही हूं, तो ये खिचड़ी में ग्रेट क्या है? ग्रेट क्या है? ग्रेट विल बी अगर मैंने उसमें मेरे घर का बनाया हुआ घी, some new type of achar and some new type of papad is going in that khichdi, then only it is novel. Otherwise, what is there? Why will I do that? So that always comes when your publication, when you're going, and your publication comes when you're doing that research. So something novelty has to be there. It cannot derive rates, but it will derive proportion. This is what coming when you venture into statistics. Cross-sectional study, something more than a case report or case series. That as a clinician you can start with. Cross-sectional meant snapshot. It's actually a snapshot of your whatever research question that you're doing. So it could be that finding prevalence of disease or variable. Okay, it's very easy. You want to find out what is or you want to audit your own practice. You end up doing a cross-sectional study. Or you want to find out what are the changing, patients which have come to my practice today. So you find out what are the various types of patients who came, and that becomes your cross-sectional study. In cross-sectional studies, remember, your question is very, very descriptive. Like the way I said just now, I want to find out what are the different audience characteristics of attending this workshop. It's a simple cross-sectional study. I had one questionnaire, I asked information from you, I collected it, it is a cross-sectional study. Okay, how am I going to analyze it? I am just analyzing descriptively. How many male, female, what is the mean age group, which type of specialty you belong to, which type of clinics you and hospitals you're attached. This is the way I would come with the result of such type of a study. This is a simple cross-sectional study that I have done. Coming to longitudinal descriptive, I do a follow-up study. ICP API is going to do series of, madam said in morning, she is going to do a series of this way research workshops. Every workshop, I do the same thing as a researcher. I collect the same audience data. And then over a period of 1 year, I try to find out what is the mean age on the type of audience, the type of specialty attending these workshops. And I try to come up with certain trends. This becomes a longitudinal descriptive study. Remember, we are still with descriptive. We are just describing. There is no comparison anywhere anyhow. Longitudinal is, it's a cross-sectional study being conducted at multiple times. So I end up calling it a longitudinal study. I am taking, remember it's a sample from the same population. Every time it may be a new or it may be the same. Remember just now when I gave example, audience attending these clinical research workshops, every time the audience is going to be different. But it is my longitudinal study. Today's audience coming after 3 months, audience coming after 6 months, because madam is running this research workshop series for over a year. And my research is to find out the difference in this audience which is attending this research workshop, is my research question. So this is again a longitudinal study. So I end up getting the natural history of the disease or progression of health related variables, or I will come out with trends. That can happen. Okay, so this is what would end up with a longitudinal. Okay, so same thing diagrammatically. Remember that you have a longitudinal descriptive study versus a cross-sectional. Longitudinal obviously multiple times. So remember, don't forget what Nithya madam said, feasible. If this type of research question if I have to do, then every workshop I have to be present to collect the data. Okay, cross-sectional, today I came, I collected the data from you and finished. That is cross-sectional, over. Longitudinal, every time point I have to come, collect that data and accordingly I am going to analyze. Okay, ecological studies. It's nothing about individual, it's about group of people. You as a cohort or you as a group, I follow you up. I follow this group, I'm not following individual of you. I follow this group. Okay, after 3 months, 6 months, and my now question is, what are the research studies that you people are planning? Descriptive only, no comparison, nothing. And I after every 3 months I ask you, madam, आपने कोई research study plan किया क्या? Sir, आप कोई research कर रहे हो क्या? Ecological study. And I'm doing this after 1 year, 2 years, I continue doing this. I'm not individually tracking you, I'm asking you individually, but I am going to present as a group. Okay, there's a madam told that some 1 year back and now there was some 30 papers, that's of the group. All 30 papers did not come from 30 individuals. They were from, one individual could have done 15 papers and others might have done 0, but I'm tracking that group, that makes it an ecological study. Okay, so fine. Needs assessment, very common type of study that you and I could again very well end up doing. What is the need of my patient population? Need assessment typically are surveys which are done, and that is why they are also called in healthcare research as community diagnosis. You do a needs assessment survey of your patients coming to your clinic. Okay, what good healthcare they want from your hospital? Let us imagine that. Patients tell you they want more doctor consultation time, they want better rooms, or they want better whatever. And accordingly, you improvise, you bring some novelty, and accordingly change. So these are simple need assessment surveys that you are doing in a descriptive setting. Again, no comparison, no hypothesis testing, no assumptions, nothing are coming in place. Okay. Up till now, these were all descriptive studies. Or everybody is on board? Because remember, this is apna revision class. Baad mein there are some 4 or 5 questions which you have to solve. And I'm hoping that all the answers will come correct. There cannot be any error. Okay, so this is up till now was all descriptive. Very easy type of studies to do. I'm a keen observer, I'm observing and I'm doing it. Now I'm under descriptive heading only, but I'm now venturing into case control and cohort study. Many times you and me thought that all these case control cohort studies are done by people of community medicine. Park में एक chapter था इस पे और एक question exam में आता था differences between case control and cohort. It's not that way. Case control cohort, even you and I can do. It's not restricted to community medicine. Remember, we are still into descriptive only. Okay. Case control, all of you are remembering that smoking and lung cancer example. Even in sleep, everybody will answer. Okay, very standard. Take cases of lung cancer, ask them if they smoked or if they did not smoke. Control was who? No, control was who? No, control, case control. So control was who? Non-lung cancer patients. Not non-smoker. Control was non-lung cancer. Because everywhere when you're doing case control, it's a case and a control. We can have another workshop on how to do case control studies also. Huh? Because how to select cases and how to select control is the skill. Okay, but case control, when we are saying, we are starting the study somewhere over here. We are taking cases with lung cancer. Okay, we are taking controls who do not have lung cancer. Control, simple definition, is not with the disease in question. Is a control. Is a control. Okay, what are we going to do? What is now our research question? We want to see whether there is this exposure, but my research question is not descriptive khali. I just only want to see. I want to see the association of that exposure with that disease. So my research question slightly evolves. It is not that descriptive simple. I just want to see how in lung cancer patients, how many are smokers or non-smokers. It is not ending with that. I want to associate whether smoking is there with lung cancer patients. Okay, is it associated? Remember, the word is associated. Is it associated with lung cancer? And whether smoking is also associated with non-lung cancer also. I want to do this now. So now I am entering into what Nithya madam described, an analytical type of question. Because it is descriptive, but I am getting a control, a comparator in picture. One step higher. वो simple descriptive मेरा cross section longitudinal नहीं है. Now I am going one step higher. So what is that one step higher? I am taking cases. I am also taking controls. Okay, and I am trying to ask these cases whether they smoked or did not smoke. I am also asking controls whether they smoked or they did not smoke. Clear? It is there have become two groups. There is no intervention over here, still descriptive in the broad heading, observational study, but now it becomes analytical. Why? Because I am putting an assumption in place that smoking is associated with lung cancer. My research question is to evaluate whether smoking is associated with lung cancer when I compare him with controls. So my research question became in that there is something called as PICO and there is something called as PECO, P-E-C-O. Patient, exposure, control and outcome. So now I am going into that level of a research question. My research question complexity is getting evolved because I am going to a case control type of design. Okay? Everybody on board? Good. Okay? So case control, the research question is not a very just descriptive. My research question is going in that PECO format. There is a patient, there is an exposure, there is going to be a control and there is an outcome that I'm wanting to study. So usually, and there is a hypothesis now to be tested. Up till now, descriptive studies, there were no assumptions I was making. I just wanted to see, my same example, I just want to see whether, what is the audience characteristics attending this workshop. The moment I make this assumption, the participants attending this research workshop will be planning more research studies than participants not attending. ऐसा जब मैंने सोच लिया, I will enter into analytical study. My research question has evolved. Okay, so great. When I'm doing case control, usually the disease is rare, exposure disease interval is very long, it is association of the disease with more than one exposure. Okay, and remember in statistical language, these are all called as association testing. It is not always a cause-effect relationship. Though we tell that smoking in general, you tell smoking leads to lung cancer, but in statistical language, these are all association testing type of studies. Remember, there is a hypothesis which came into play now. Okay, so we go ahead, that was case control. Coming to cohort. Cohort is a word actually meant a group of people. Many times as a clinician, you will say, oh, I'm doing a cohort study. But that does not mean cohort design. Whenever you are following a group of people, okay, for a particular outcome, it is a cohort. Most of you must be familiar with Framingham cohort, cardiology. Okay, but that Framingham cohort is not a cohort design. Like I am taking you as a cohort and I'm following up you whether you do research studies. This is simple longitudinal cohort that I'm following a group of people. What is a cohort design? Let us go to that. Cohort design is same diagram. There are people with disease in question and there are controls again with not with the disease. But here I am starting from exposure point of view. That means same lung cancer smoking. What I am doing, I am taking individuals with who are smoking, and there will be a group who is now, agar cohort design hai, to which will be the other group? Non-smoking. Now it is cohort design. So I am taking a group who is smoking, I am taking a group who is not smoking, and I am going to follow these people for 2 years and see how many of them develop lung cancer. So smokers at the end of 2 years developing lung cancer, not developing lung cancer, non-smokers developing lung cancer and not developing. This is cohort design. I just following up you for some XYZ outcome does not make it a cohort design. That is just cohort, following up of a cohort. When I write study design as cohort, I start from the exposure. Okay, many times in clinical practice you and me tell, अरे वो case control या cohort वो मतलब एक ही तो है, वही exposure, वही smoking और वही lung cancer. No, it depends as a researcher where I am starting and what I am looking at the outcome. If I started with lung cancer and I am tracking back, it is case control. So then I should know who are my cases and my controls. When I'm starting from exposure, then I have an exposed group versus a non-exposed group. So the example that just now I gave you, you attending a research methodology workshop and a group not attending, you are exposed to a research methodology workshop, other group is not exposed. Outcome is doing and publishing a research study. It will become a cohort design. Clear? Great. Sir, research idea, you can do this. And it will be publishable also. People who didn't attend today, na, wo jitne bhi aapke API members hai, are in that non-exposed group. The group is also ready. Everything you can. Nahin, why I am giving such examples is that research is there. Madam said, research is there in your everyday life. You really don't have to Google search or do ChatGPT to get a research idea. You can do aram se. Only you should have dedication and commitment. Like Supe sir and Nithya madam 24/7. That is very important. Yeah. Okay, so cohort, expose, unexpose. You start from here and then you are following them up. Okay, and this was that great question in 3rd MBBS which you and I wrote for 5 marks and 7 marks. Okay, why this is important is today if I am doing case control after disease, this is before. This is rare exposure. Remember, both are association type of studies, both are hypothesis testing studies under the banner of observational. Remember that also. But they come under hypothesis testing. They are not simple descriptive studies. Okay, so and because they are hypothesis testing, case control, the statistic that you need to calculate will always be odds ratio. And here you always end up calculating relative risk. Okay, we are not going into what's odds ratio and what's relative risk, that we can do in another workshop. Okay, but you have to get it, because many times as a researcher I write case control. लेकिन मेरे पेपर में ऑड्स रेशियो आता ही नहीं है. आई एम स्टिल डिस्क्राइबिंग ओनली. मैं वो लंग कैंसर इतने केसेस, इतने स्मोक, इतने नॉन डिड नॉट डू स्मोकिंग, कंट्रोल में दिस मेनी डेवलप लंग कैंसर. आई एम नॉट गिविंग ऑड्स रेशियो का डेटा ओनली. बट द मोमेंट आई अटर केस कंट्रोल स्टडी, odds ratio has to come in my results. It cannot end, it cannot finish without that. If I am telling it's a cohort design, relative risk has to be calculated. I just can't describe the variables and tata bye bye. No, then I have not met what I was supposed to do. Okay? Fine? Okay. Now, observational study is over. Everybody very clear? Any doubts so much so far? All are, I'm seeing awake also. You by now must have even developed, even I have developed that skill. With open eyes also you and me can sleep. So that skill everybody has acquired by now. But I am hoping that observational studies concepts are very clear to everyone. And now we are venturing into interventional. Sir told, life में कभी ना कभी RCT करना चाहिए. So even your dream is that, हाँ? कि कभी वो अपना डिस्क्रिप्टिव केस रिपोर्ट, केस सीरीज, दैट RCT is your ultimate goal. Okay, so now we come to interventional. Interventional, remember there is an intervention. It could be drug, it could be surgery, counseling technique, whatever. And based on that, you have these different types of designs. Single group. I suppose all of you are more into diabetes, and now tirzepatide will be out. Okay, will be out. Okay, again big revolution, whatever, forget the commercial part of it. You in your practice want to study your diabetic patients before giving tirzepatide and after giving tirzepatide HbA1c. You are giving, it's an intervention, this is now not observational. You are giving tirzepatide to your selected patients before and after, simple single group. You as a diabetologist, one group you are giving tirzepatide, another group you are giving the great semaglutide. You are giving, I'm saying intervention. You are giving, designing and giving. Yahan pe bhi semaglutide. Okay, 2 groups. It will become 2 group. Moment I make 2 group, single, ye aisa aa jata hai Ram. 2 arm, 3 arm, 4 arm. You want to give tirzepatide different doses. 3 doses of tirzepatide, 3 arm study. Easy, ekdam easy. The way I do the intervention allocation. Okay, so intervention allocation will only come into picture if there are more than 2 groups. Otherwise, there is no intervention allocation. 1 group semaglutide, 1 group tirzepatide. I randomly allocate who gets semaglutide, who gets tirzepatide. Don't get confused with random selection of patients versus random allocation of treatment. When I say random selection of patients, suppose you are a big group, I randomly pick up 4 or 5 of you, is random selection of patients. When I say random allocation of treatment, you all are there, I randomly allocate somebody semaglutide, somebody tirzepatide. It is not on your choice. Okay, fine. So, based on this random allocation, my interventional study can be randomized or can be non-randomized. Why should I do this random allocation? ये इतना सब नौटंकी करने का क्या जरूरत है? एक तो intervention study, 2 groups, मेरा ही पैसा वो semaglutide, tirzepatide. Why I should randomly give patients? What is this great bias? अगर आपको 5वीं पास बच्चे को एक्सप्लेन करना था सर, ये bias is what? Most of you will think, ये bias क्या है? What is that great thing? Why? कैसे सर आप बोलेंगे 5वीं पास बच्चे को bias meant what? हाँ, partiality, prejudice, my judgments. Okay. Fine, madam, ekdam affluent family. I know tirzepatide is going to give miracle results. ऐसे सब मेरे friend को tirzepatide, मेरा जो enemy binemy sema, वो मुझे पता है ज़्यादा. This is bias. And then from these results, I am going to make policy decisions. वो नहीं चलेगा मुझे. So that is why this random allocation is very important when you are doing a 2-arm interventional study. Agreed? थोड़ा और आगे. Now, when you are saying this arm, now remember I said SEMA was my comparator. because semaglutide was already there in the market. Tirzepatide is a new. So I am going to compare. When I compare with an active molecule, okay, it becomes an active control. Semaglutide active. I am comparing with a placebo, or I am comparing with a inert sub, or I am comparing with no treatment. But there is a comparator. Why in this intervention I wanted comparator? To show the difference. Q? Better. You always want to prove that A is better than B. Otherwise, मैं भी बोल सकती हूँ, I am Miss Universe. Will you believe me? No. To make this, if this is my assumption and I have to do hypothesis testing, intervention study, I will have to compare myself and give that many tests and reach to that level. Are you getting that? So always in intervention, I will prefer this comparator. So remember, ye apna 2-arm, randomized, placebo controlled, apna design adjectives are building up. Last is awareness about the intervention. And that brings you the concept of blinding. Okay? Nithya ma'am gave you example. Double blind study, DEC, albendazole, aisa sab all was there. Okay, so when I am, now why do I need to be blinded about the intervention? Why? Intervention to मैं ही दे रही हूँ और मैं ही blind. Okay, to avoid that bias in interpretation, even to avoid bias in selection. Okay, so I will blind. Now what does this blinding mean? It means that in that also you have something like single blind, double blind, assessor blind. So depending on my design, if when I go to intervention study, remember I can have all permutation combinations. I can have a single group, okay, simple study, intervention, prospective, interventional single arm study. I can have interventional 2-arm, non-randomized, active controlled, open label study. I can do 2-arm, randomized, active placebo controlled, double blind. This way all permutation combinations will come. Okay, great. So everybody, so single group we know. Yeah, it's a baseline, you give the intervention and then you study the endpoint. Apna same tirzepatide before after HbA1c. Okay, single group, lot of bias, lot of this. So that is why you go to parallel. And to minimize bias, you did this random assignment and blinding. You did this. Okay, so again, if it's going to be parallel, remember that 2 different groups. One group semaglutide, one group tirzepatide, you did this. Okay, and you have randomly allocated them. Okay, fine. Control could either be placebo controlled, active comparator. Remember, even if you're doing surgical procedures, even there is a comparator. Either it could be a standard surgical procedure or it could be your sham procedures also. So even those end up as this. Sometimes you can take even historical controls. You don't have this, but there is data in the literature. I don't want to give semaglutide. Semaglutide ka data is there in the literature. I will pick up that and I will compare with tirzepatide versus placebo. Now types of blinding: open label, no blinding. Single blind, patient does not know whether he got sema injection or tirzepatide injection, but I know, I am the diabetologist, I know. Double blind, both physician and patient do not know who has received the injection. Double blind. All this we are doing to minimize bias. Now there is something called as double blind, double dummy technique. यहाँ पे I am comparing sema tirzepatide, both injections sort of look identical, so it is easy to blind. But imagine I was comparing, say, semaglutide oral tablet and tirzepatide injection. Tirzepatide, difficult to blind. तो फिर वो डबल डमी चालू होता है. One group will get semaglutide tablet, tirzepatide placebo injection. Other group will get tirzepatide injection and semaglutide placebo. You will tell, अब ये placebo वगैरह मैं कहाँ बनाऊंगा और बनाऊंगी? How to do all this? Okay, if it's injectable, you can anytime give a multivitamin or a water injection. This injections and all, this is very easy. Tablets and all become difficult. You may go to a pharma company. They will give you placebo tablets. You have to give nominal pay. Okay, many times it is very easy to give placebo capsules. Very easy. Only thing you and them, wo itna pharma company who is that way having sponsoring you all this, they will also give you placebo tablets and capsules also. Huh? You have to tell them कि ऐसा ऐसा मुझे चाहिए. Make use of them. They will give you. It's not that they will not give you. Okay, this was double dummy. Now, another this is evaluator or assessor blind. ठीक है वो सेमाग्लूटाइड, टिर्जिपिटाइड, इंजेक्शन, आई नो वो दिस पेशेंट नो, मुझे वो ब्लाइंडिंग बिंडिंग इतना झंझट करना ही नहीं है. तो व्हाट आई विल डू, आई विल टेल माई कोलीग, माई अदर डायबिटोलॉजिस्ट, दैट डायबिटोलॉजिस्ट विल डू ऑल द इवैल्यूएशन. दैट अदर कलीग ऑफ माइन डजंट नो हु गॉट सेमा एंड हु गॉट टिर्जिपिटाइड, एंड दैट अदर कलीग हैज टू बी एकदम प्रॉपरली वर्किंग. दैट अदर कलीग कैन नॉट डू नौटंकी एंड आस्क ये तुझे क्या मिला. And अच्छा सेमा okay तो HbA1c बढ़ने ही वाला, ऐसा that colleague can't do. That assessor is really blinded. Okay, so that is most of the time you may end up doing this assessor blind. No problem. So your study design will become 2-arm, randomized, active controlled, assessor blind study. But you are doing good. Okay. There are other complicated designs. You may venture into all this. These are factorial designs where you have 2 doses and 3 doses and you then intervene. Like say for example, I am giving sema with metformin, tirzepatide with metformin, different dose of sema, different dose metformin, factorial design I will venture. Okay, all this can be done. Okay, similarly there can be withdrawal design. Imagine that same this many times, like say for example you have patients on background diabetic anti-diabetic oral drugs, you withdraw those drugs and then start sema and tirzepatide, so you are putting a withdrawal design. Or you may also give the intervention, see how many are responding and then randomize them. Okay, even those type of designs come into play. Okay, so accordingly you may have all types of permutation combinations which are there. Then we go to something called as crossover. Up till now we were with parallel, one group sema, one group tirzepatide, we were running that way. Now crossover design is you give an intervention to the patient, you give a break which is called as a washout period, and again give different intervention to the patient. We can take that same sema and tirzepatide, you gave semaglutide 6 months, you really wash out semaglutide for 1 month, now give tirzepatide. This is crossover. Obviously you know that crossover designs will work only and only when your disease is chronic. Acute, if I am taking acute attack migraine, where is the question of doing crossover design? The attack got resolved, na? Okay, so you have to know which type of designs that I am going to use. So this was crossover. This was also another exam question you and me answered. Okay, point to remember is that parallel, shorter duration but larger sample size. Okay, there is no carryover effect. You are doing those between comparisons and all. Crossover design is very good design to pick up individual variations in the same patient. Same patient responding to sema, same patient responding to tirzepatide. So all these things matter. It again depends what you wanted to study. Okay, Latin square, again a complexness of crossover. We can skip this. There are other designs like sequential, add-on trials. Sequential is I finish 1 dose of the drug, they are responding, then I put the same patient on a higher dose. That is sequential. Okay, add-on designs, add-on background anti-diabetic therapy is going on. I am adding sema tirzepatide add-on trial designs. Okay, you may go to something called as placebo run-in, compliance run-in, and today the people have gone to adaptive trial designs. This is what you need to know. This is the highest level of designs that you could end up doing. Okay, these are your adaptive designs. Okay, now up till now we did observation intervention. There is another way of classifying study designs, is whether my study had an assumption or hypothesis, and whether I want to study an assumption. Whether I want to study that, I'm making that assumption that people attending this workshop are going to do research studies, whether I want to test this. If I want to test this assumption, I am going into hypothesis testing type of design. I'm making no assumption. I am just looking at you, following up you for 1 year and just capturing the data. At the end, I may generate कि all those who attended that workshop, they did research studies, Baba. This is hypothesis generation. So hypothesis testing, when I am going, in observational setting, there are case control cohort studies. In interventional, there are randomized control trials. Okay? In that randomized control trials, you can have superiority testing, equivalence and non-inferiority. This is just for you to sensitize. So, sorry, many times, oh God, many times you want to prove, most of the times you want to prove A better than B, terzepatide better than semaglutide. You want to prove superiority. That's how you will work out. Equivalence, both are same. The brand of telmisartan, say by example by Cipla, and brand of telmisartan by Pfizer, both technically have to be equivalent. Both have to be same. So that is where I go to an equivalence hypothesis testing. Remember, it's still testing. Or non-inferiority. I want to say that SEMA is non-inferior to tirzepatide. It means what? That SEMA and tirzepatide, if I fix a non-inferiority margin, SEMA is coming in that. Let me explain you this with another example. Say for example, I am comparing myself with madam. Both of us are giving exam, or wo bhi medicine, and I am now pharmacology. And imagine this is on say clinical diagnosis and management. But I want to prove that कि I am better than madam. हमारा एकदम surprise test है. So I have to, then my assumption is what? I am supposed to score more marks than madam. This is superiority. But now tell me, imagine that this exam is of say 100 marks, madam gets 90, and I also by fluke get 91. एकदम चौका लग गया मेरा भी 91. Will you call me superior? नहीं एकदम stand still. Now they don't know what to answer, whether they should support you or they should support me. You don't have to support me at all, because I am a pharmacologist. कुछ भी ये नहीं है. So superiority, when I am saying, remember when the pharma companies are telling a drug is superior, they have to clearly statistically prove that effect is superior. So when I have to say I have to be superior than madam, okay, I have to really that mean marks have to be statistically better than madam. ये एक mark is not considered superior. वो वैसा वो मैं एक vote से जीत गई, that वो नहीं चल, that is not superior. Equivalence. Madam 90, मैं भी 90. Equivalent. एकदम ये. Now come to non-inferior. Madam 90, मैं 88. But I don't want to declare myself as inferior, because I did an assumption or hypothesis testing that if I am non-inferior to madam if I score marks within a difference of 2 marks. तो मुझे भी 88 मिल गया. तो मैं, remember the statistical language is non-inferior. Non-inferior doesn't mean that I'm equivalent or superior. I am just non-inferior to madam. Okay, if this same thing, if I have to show diagrammatically to you, this superiority, way ahead. Equivalence, again there is a margin. There is an equivalence margin. Okay, so I tell that I have to get my marks, I will consider myself equivalent to madam if I get marks plus minus 2. So अगर madam के marks 90 आते हैं, I get 88 or I get even 92, I will be considering myself equivalent to madam. I cannot say 92 so I am superior. Remember that. Because my equivalence margin was of 2 marks. Now, come to this great non-inferior. Ye non-inferior hai. So I make an assumption that I am going to give the test and my non-inferiority margin is of 5 marks. It means Madam is getting 90, I must get 85 and above. If I get marks less than 85, then my non-inferiority is lost. Is this explanation clear to all of you? Agreed. Fantastic. Marvelous people. Good. हो गया आपने. This much if you have done. Okay, why did we break head with designs? And why did Supe sir said कि कभी ना कभी एक RCT आपके नाम पे और publish होना चाहिए? Because everything is evidence based. Remember sir told in the keynote address, your entire practice is evidence based medicine. And the highest level of evidence is when your evidence is from meta-analysis of RCTs, a randomized control trial, wherein it was double-blind, it was 2R, it was active controlled, and there was no element of any bias, or bias was minimal. And that is why RCT design becomes at highest level. Okay, if you look, whenever you are reading all your treatment guidelines, remember this level of evidence is given. Whether you read AHA or you read NICE or you read Indian Diabetes Association ka guideline, there is a level of evidence which is given over here. And that evidence comes from this. So you will say, वो RCT, वो meta analysis कोई और करेगा, मुझे तो खाली treat करना है. लेकिन it is always good कि अगर ये RCT मैंने खुद ने किया है और मैंने prove किया है and I am only practicing. Okay, all of, since diabetes, you can also be that V Mohan and prove. और वो पूरा guideline आपके नाम पे आता है. वो एक अलग dream है. Okay, and you change the practice. And then you become the key opinion leader in your field. So that is what madam said. Where is the difference? So it's everybody, all of you are excellent in your practice. You want to be that key opinion leader. Okay, that is where research and research into publication will matter to you. And in that research, just making that khichdi every day, case reports, मतलब नहीं है. अपने को वो बिरयानी और वो भी वो केसर वाली बिरयानी एकदम मस्त लेवल पे जाना है. And you want to reach here. This is the dream. Okay, I think that's, now the test. Chalo. Now everything I have finished teaching. And all of you are ekdam awake. Now, you have to just tell me the design. Clinician wants to assess risk factors of peptic ulcer in patients visiting his clinic, his or her clinic. What design researcher will do now? If this is the type of question, what design? Simple observation, and it is cross-sectional. All of you are agreeing this is simple observational cross-sectional study. Okay? Clinicians want to associate if peptic ulcer is due to consumption of spicy food. नहीं, अब मेरा association आ गया sir, ये word मैंने use किया. So, this will become case control. Who are the cases? Peptic ulcer. Who are the controls? Without peptic ulcer. Without peptic ulcer. And what am I asking them? Simple question. Do you eat spicy food? Do you do not eat spicy food? Remember, what is spicy food? I have to define. ये मेरे, when there is a workshop on protocol writing, sir, तब ये सब भी matters आएंगे. Today we are on एकदम simple things. Okay. Clinician wants to associate if spicy food could lead to peptic ulcer. Cohort design. Now, I am taking patients who are eating spicy food and patients not eating spicy food and following them for 1 year. And what outcome I am looking? Peptic ulcer हो रहा है या नहीं हो रहा है? एकदम simple. Everything is. It is exposure to outcome. Exposure to outcome. Remember, at the end of the day, you feel that even exposure is outcome and even outcome is exposure. That trap we don't have to fall. We as a researcher have to be very clear. Now look at this question. Clinician wants to calculate the daily quantity of spicy food that will lead to peptic ulcer. ये कैसे करेगा clinician? अगर ये करना है मुझे तो, RCT, so how this RCT will go? So 5 gram spicy food to one group, another group 10 grams, another group 20, one group with no spicy food, and then see peptic. This becomes a random 4-arm, randomized, control, maybe assessor blind study. Okay, now the $1 million question comes. This becomes intervention. Pehle researcher was all under observational. Remember, the way my research question changed, my design is changing. The way I am going from hypothesis, no hypothesis to hypothesis testing models. Okay. Now this type of research study, can I do today? No. Why no? Why no? नहीं, it is not novel, वो तो जाने ही दो, वो तो अलग ही बात है. Correct. Not novel is correct. But can I do this way intervention today? Ethical, and that is where Durga madam will take you. Okay, when you enter RCTs, where is the ethics? You cannot do such type of study today. But I can do semaglutide, tirzepatide, metformin with dapagliflozin. Yes or no? Yes. Intervention study. 3-arm, I am intervening, this is not observational, remember that. I am randomly allocating them, I am doing a assessor blind, so that will make it randomized control trial. Okay, now last question, if you answer, then you have done my day. Chalo. Okay. All consecutive full-term normal births in a year were studied in a teaching medical college. Each infant's birth weight was measured. And at the same time, the mother's attendance at antenatal visits were ascertained from the records. Antenatal visits were classified as satisfactory and unsatisfactory. Up till now, question is clear? Infant wo jo bhi simple ye. Analysis of data showed that mean birth weight of infants born to mothers who had satisfactory ANC attendance had mean birth weight higher. 2 infants born to mothers with unsatisfactory attendance. This difference was statistically significant. What is the study design and why? Now what is the study design? सबसे पहले, is it observational study or interventional? All of you are agreeing it's observational. Very good. Now, if it's observational, is it a simple descriptive study or it is something beyond that? It is analytical. Now analytical, अपना case control में fit हो रहा है या cohort में fit हो रहा है? What do you think? नहीं, there are 2 cohorts, but it is not cohort design. See, अगर मेरा cohort design रहता, then I would have started the study from where? नहीं, started the study from mothers attending antenatal. The exposure is mother attending antenatal clinic. Mother attending antenatal clinic versus mother not attending antenatal clinic and seeing if infant is born normal weight or no. मैंने स्टडी वहां से स्टार्ट किया क्या? नहीं, आई एम वेरी स्मार्ट. बच्चा सब हो गया है, मैं वो बच्चे का वेट एंड आई एम लुकिंग एट रिकॉर्ड्स. सो दिस इज नॉट कोहॉर्ट डिजाइन. All of you are agreeing? Okay. Is it case control? Because what is the outcome? What is the case? The infant. But am I looking? I am just recording infant's birth weight. There are no those groups. Infant with normal birth and infant with low birth. ऐसा group नहीं है. There is no control. I have just got the data. And I have, after analyzing, I am coming to this great conclusion. This is neither case control, neither cohort design, but it is cross-sectional analytical study. Correct, cross-sectional analytical. In that same cross-sectional descriptive, I am smart enough to draw these comparisons. Okay, I was a simple medical officer working in that ANC clinic. I have recorded the birth weights. I stratified them as normal birth weight and whatever. And I just looked at their mother ka records, whether unka ANC this is correct or not correct. And then I draw this statistical conclusion. So this becomes a cross-sectional analytical study. Simple cross-sectional से ये थोड़ा better. खिचड़ी with अचार with पापड़ with मेरा घर का घी. Cross-sectional analytical study. Do you think such type of studies are doable in your practice? You are not always going to venture, but this type of analysis will make you that 1 inch higher, and you will be called to give speaker as in the conference, because ये आपका day to day है. The way you analyze it, the way description is just description. But the way I analyze and draw conclusions will make me go into cross-sectional analytical study. I think I have done. Thank you for a patient hearing, and thank you for all being there. You need not stand for me. You are my teachers are there in the audience. All teachers. Really thank you, ma'am, and thank you for the opportunity. I am hoping that there will be no questions. I also made an assumption that मैं अच्छा सिखाती हूँ तो questions नहीं आएंगे.
नहीं, madam, in fact, there are many PG students also, and some PGs will be now entering that cycle of ethics committee submission and all that. So if anybody has any questions, madam is most welcome here. Yeah, please.
Hello.
Yes.
Am I audible?
Yes, sir.
Now there are semaglutides and there are the biosimilars. Lot of companies says that the biosimilars are not original. Okay. Now DCGI gives approval to these drugs, biosimilars, on the basis of only pharmacokinetics and pharmacodynamics. Okay. Should they undergo for any equivalent study in post-marketing surveillance, or they should go over the cross-sectional study?
Sir, I'll answer this question.
Yeah.
Nithya madam and even Durga madam can add.
Mic.
Remember, whenever your biosimilar, sir uttered the word biosimilar.
Yes.
Sir
Mic.
uttered the word biosimilar. So whenever a biosimilar is getting marketed, okay, remember that it is not a simple equivalence. Many times your biosimilars, the regulator will want to undergo a phase 3 clinical trial. It is not that simple equivalence of telmisartan Cipla, I'm just taking this for example, telmisartan Cipla and Pfizer Cipla, where they undergo bioequivalence study. Okay, if it's a biosimilar product, it is usually a phase 3 clinical trial. And again, I have not ventured into clinical trial versus a prospective interventional study. All your clinical trials are prospective interventional studies. When clinical trials in India, as per the law, clinical trials word when you utter, that time your intervention is a new drug which is not marketed in the country. Okay. So when you utter the word clinical trials, the context is you are working with a new drug. But to answer to your question, it's not that when the biosimilars come in the market, it is not being evaluated or not been tested by the regulator. It has undergone phase 3 clinical trials. Ma'am, you want to add? It's done. Sir is telling that post-marketing may, so remember post-market, because it's a biosimilar, the company has to provide safety data at least minimum for 4 years. Okay, so that all the company is doing. Madam, come here.
If they're doing bioequivalence, it's usually with an oral formulation. You know, so if a company has got an oral formulation and they want to, some other company wants to market that same oral formulation, in the first 4 years of getting marketing approval, they have to do a full-fledged phase 3 clinical trial. But if the first 4 years are over, then that company can do a bioequivalence study with that oral formulation. And then say it is equivalent to the originator. And then they get a marketing authorization, and that's quite often also given at state level when the drug is quite old. So when it becomes a generic drug. So the difference between biosimilars and small molecules or oral formulation. Yeah. So generics can undergo bioequivalence after the first 4 years. Because in the first 4 years, for the first 2 years, the company has to give periodic safety update reports every 6 months. Then they have to give annual updates for the next 2 years. So 4 years, it's considered as a new drug. Is that clear?
Yes, sir.
Not covered drug development. Not at all. There are biosimilar guidelines available, as ma'am has said, and the entire drug development goes under the law of new drug clinical trials, NDCT. NDCT 2019 has got many updates. So all pharma companies, when they are getting today drugs in the market, they are following the regulation, and it's a law of the country. So it is at that level. So any other question?
Yeah. Madam, I am Dr. Anil Jetwa. I wanted to know how many clinical pharmacology seats are there right now? And can we have a...
Okay, first I will answer one thing. Remember, for this of the audience, clinical pharmacology is a super specialty course. Clinical pharmacology is DM clinical pharmacology. In KM, in our institute, clinical pharmacology department and pharmacology departments are different. So DM clinical pharmacology head is Nithya madam. And how many seats are there in DM clinical pharmacology? Madam will answer.
3.
I will answer how many seats are there in MD pharmacology.
Sir, actually, all of us, you are also a clinical pharmacologist. Anybody who has done medicine, anybody who has done general medicine.
No, but I heard that only students of MD pharmacology can pursue clinical pharmacology.
Correct. And MD medicine and MD community medicine.
And
There are
MD
3
community medicine.
MD.
Okay,
Yeah, so
okay.
there-
Thank you
so-
very much. Thank you.
but
In India, there are very limited, sir.
Yeah, I know.
colleges.
In
yeah.
fact, you know, my nephew, he did Pharm D from Pune. So that is another.
Yeah, that is non-medical.
Yeah, so these are all related to pharmacology, but different degrees to be pursued. Yeah.
Yeah.
So whether Pharm D people can intervene like this? No.
Because there is a medical qualification needed. You need an
So
MBBS.
for
that's
clinical
pharmacy.
pharmacology, you require pharmacology, medicine, and community medicine.
Or
Either of them, of course.
let's, yeah, later, no? We can.
I did a very strong assumption. No? There will be no.
Dr. Raakhi madam, we cannot let you go without felicitation. I would like to call upon stage Dr. Nithya sir for felicitating madam, and a big round of applause for the way she solved all the research nuances with that explosive, interactive, intriguing talk that she has had here. And with this, I think we will break for a tea break of about 10 to 15 minutes, and subsequently we will gather for the talk on ethics, and then a panel discussion where all the questions from the audience will be addressed, and we will have a good interactive discussion later. So 10 minutes of tea break that we have now.
So our next lecture is on importance of ethics in clinical research, protecting clinicians and participants. And I would like to invite Dr. Durga Gadgil madam to give this deliberation. Madam is a clinical research consultant and NABH assessor, 30 plus years in the pharmaceutical industry and 10 plus years in academia, and none other than madam who will justify this important topic on ethics. Thank you, madam.
Okay. At the outset, I'd really like to thank Nithya and all the organizers for inviting me here. I'll be moving the focus a little bit from, generating a research question, then which statistical tests to apply, which study design. So let's shift the focus a little bit and move to ethics in clinical research. And why is ethics very important? Ethics means doing the right thing when you're involving human participants. Nowadays, we do not call the research patients as patients or subjects, but they are called participants for the simple reason that they are part of your research. Because if they were not gracious enough to agree to be part of your research, you would not be able to do any research. However good your research question is, however beautifully you have written the protocol, you have planned a very good study design, but these participants have to agree to be part of your research. Only then can you generate questions and then do your research. So some examples when you say doing the right thing, what does it mean? It means allowing the patient to become a participant by giving voluntary consent, so taking their informed consent, making sure that these participants' safety and well-being is of primary importance, because we are all clinicians first, and therefore a patient's welfare is our primary responsibility. Also maintaining confidentiality, because you collect a lot of information when you are doing research. So make sure that this data that you collect is kept confidential and none of the patients who are participants get identified because you have not kept their data confidential. And of course, when you're doing research, report these side effects honestly. I've put the quote side effects because while doing research, we don't call them as side effects, we call them as adverse events. So any event that happens to a participant in the research, they have to be reported honestly and correctly. Why is it important again? Because clinical research, besides protecting participants, ensuring voluntary participation, you minimize the risk, try to maximize the benefits as far as possible. But remember, you want to generate reliable data. We've been hearing about this right from morning, that what you want to do is generate reliable data which you can then apply as an evidence when you're treating your patients in your clinics. So you're generating data which has to be reliable, which can be considered as evidence-based, which you can then use while you're treating your patients. And by doing that, you'll ensure that there is public trust in whatever you do. So when you've done your research, you've generated data, you've protected the participants, you've taken care of their well-being, you've minimized their risks, enhanced benefits as far as possible, then you are ensuring that there is public trust in how you treat your patients when they come to your clinic. Imagine if any of us were asked to be part of a research study and you want to be a participant. Would you like to be a participant if none of these safeguards are in place? The answer would obviously be no. Why us, anyone from our family, even our friends? We wouldn't want them to be in research unless the research ethics are being followed, right? How many times you all must have had some patients come to you saying, I went to this hospital, this doctor has told me there is a research study going on, they want me to be part of it, should I take part in the research? And then you ask them, what is the research all about? Do you have any document to talk about it? Yeah, and then you also go through it and then you tell the participant what you see or what you're reading in that research study document that has been given to these participants. So remember, none of us would want to be participants in research unless safeguards are in place and the research is conducted ethically. When you look at the main players in research, it's very clear there are the sponsors. Then there is the investigator. Investigator means the clinician, the doctor who's doing the study is now labeled as an investigator. Okay? The sponsor can be a pharmaceutical company or an agency giving study grants, or it could also be the investigator himself or herself taking on the role of the sponsor. Okay? And of course the ethics committee. So without having an ethics committee approval, you should not do any type of research, whether it's observational or interventional, any type of research, especially when you want to publish or when you want to project it in some forum, is a poster or a presentation. The first question you're asked is this research proposal ethics approved? So ethics committee plays a very, very important role. And like I said, of course, the participants, they are no more research subjects. They are participants. They are part of your research. And therefore, it's a joint responsibility of the sponsor, the investigator, the ethics committee, and their joint responsibility is, when you're doing research, protect these trial participants. That's your primary aim. You want to prove your hypothesis, you want to test the drug, you want to do the study, that's absolutely fine. But make sure that these participants are protected every time in any type of research. And therefore, we are having this session because you need to integrate this ethics training in research activities, because this makes every player, whether it's a sponsor, the investigator, ethics committee, prepared to face and handle all the ethical dilemmas that you could face when the research is going on. Okay? And once you integrate this training of ethics, the roles and responsibilities of each of these players is very, very clear. They understand what they are supposed to do, how they are supposed to do, and because whenever research is done, remember there is always compliance to 4 aspects which have to be followed. One is compliance to protocol, then is compliance to your national regulations, then your national and international guidelines, and lastly the SOPs, the standard operating procedures, which are required for every investigator to have. What is your standard procedure when you're going to do this study? So compliance to protocol, compliance to regulations, compliance to guidelines, and standard operating procedures. This is very important because this is listed in your guidelines and regulations of the country. So because it is mandated in India, you have to have these processes in place as well. And any research study that you want to do, Nithya madam talked about how to raise the question, Raakhi told us about the study designs and everything, but all this you have to write in a well-formulated protocol. And that protocol then has to be approved by an ethics committee, and only then can you start venturing into doing the research. Because imagine if there is non-compliance to any one of these activities. You do not follow the protocol, you do not follow the guidelines, you do not follow regulations. It can lead to a lot of anguish for the sponsor, especially companies who are wanting to bring a new drug in the market. So pharma-sponsored studies where they want to bring a new drug, if there is non-compliance, that data gets rejected by the regulatory authorities. So non-compliance can cause a lot of financial harm and hardships to the sponsor. To the investigator itself, maybe you all have read in the papers recently that at one center, some investigators have been banned from doing research. I don't know if you all have read that in the papers, but that's something no researcher wants to face, that they have been banned from doing research. So their credibility is at stake as well. The ethics committee gets questioned. What were you doing when you had to look at patients and participants' welfare in mind? And last of all, imagine the participants. They have agreed to be part of your research, and then this entire research is dissolved because you all have not been compliant with the regulations and the ethics. And all these regulations, guidelines, they all talk about ethics in conducting research. Why are we talking about ethics in research at all? Okay. Actually, tragedies have led to formation of codes, standards and guidelines for research. So a lot of wrong things happened in the past, and they still continue to happen, but some of them were very, very important, which brought about this need to discuss ethics in research. We all have heard about the experiments that were done in prisoners of war during World War, all the atrocities that were committed on these prisoners, so they had no say in the matter. They all were subjected to various type of research activities, and it was not for any betterment of these prisoners, it was for the betterment of the soldiers or for understanding more about sciences. Then came the thalidomide tragedy, and we all have heard about what happened with this thalidomide use when it was used for preventing morning sickness in pregnant women. It was more in Europe. Fortunately for the US citizens, there was one very vigilant FDA officer, okay, who saw that there was insufficient animal data, insufficient safety data, and she refused to let this drug be marketed in the US. Otherwise, the tragedy would have been many, many more fold. So that was a thalidomide tragedy, which led to, again, some guidelines and regulations to be put in place. The Tuskegee syphilis study, this was a study done in USA, started in 32 to evaluate the progression of this disease, progression of syphilis, acute, subacute, chronic. It was done in a small population in African Americans in a small place called Alabama. No consents were taken, no approvals were taken. This study went on till 1972, when incidentally an investigator or a journalist stumbled upon this whole study. Imagine, for syphilis in 32, there was no penicillin, but penicillin was then found. It was found to be effective in treating this condition, but these patients were denied that treatment, and because of which there were again new standards that were, and guidelines and principles that were laid down. So these are some of the events which really changed how clinical research is done the world over. Okay? What should be the ethical guidelines that had to be followed? So after the World War, it led to the court case in a place called Nuremberg in Germany, and they laid down a number of codes while doing research. The first and most important one, and that was that consent has to be taken from participants, or they were called subjects at that time. So without consent, you cannot put any patient into, or any person, human subject, into a study. That was part of the Nuremberg Code. Of course, then it also said there should be animal experimentation first, there should be a written protocol, and many other aspects were listed. But Nuremberg Code for the first time talked that there should be consent from the human subject who wants to, who should be, or who wants to be, or who is subjected to any type of research. Then came the World Medical Association, which laid down this Declaration of Helsinki. This was in 1964, but remember, this is a working document. The first meeting was in Helsinki, so it's called Declaration of Helsinki. It has had many, many revisions. The last one was in January of 2025, or September of 24. Yeah, I think it was in September of 24. So these are all updates which are happening all the time, and this was the first time the Medical Association gave guidelines to their members, to all the physicians, on what ethics should be followed while doing research. That's where they actually talked of not just informed consent, but written informed consent from every participant. Then they talked about a detailed protocol that is to be written, which has to be scientifically sound. It has to be approved by an institutional review board. That was also mentioned for the first time in Declaration of Helsinki. Then there were lots of updates and revisions which happened, which talked about the use of placebo in clinical trials. And the latest one is incorporating all the newer technologies, because now we are hearing of many, many new technologies being used in clinical research. There are wearables, there are data that is collected from EMRs and many other sources. So this Declaration of Helsinki in 2024 came up with an update on how to do research in this newer technological era. And the fallout of the Tuskegee syphilis experiment was actually the Belmont report. Okay, and I'll show you the next few slides on what the Belmont report says, which has become a gold standard actually for all of us doing clinical research. So these codes, standards, guidelines therefore changed clinical research worldwide. So 3 ethical principles, these were predominantly described and they're written in great detail in the Belmont report. It talks about autonomy, it talks about beneficence, and they've added non-malfeasance, and they've talked about justice. I'll just show you in the next slide what it means. Autonomy means the right to choose. We all have a right to choose. Every day in our life, we have a right to choose. What to wear, where to go, what to eat, what to dress, which bank to have an account, which college to study based on our marks. So we have this autonomy. Similarly, every subject, every human subject should have the right to choose whether to be part of the research or not. Okay? So they have to be allowed to give written informed consent after they are told everything about the study. And this report also talks about how do you protect people with loss of autonomy or less autonomy. So what do you do with children? What do you do with pregnant women? How do you take care of marginalized society? So there have to be some safeguards put in place if there are such participants who have going to be enrolled whose autonomy may be questioned or they do not have the right to choose all the time. So it focuses more on that as well. Beneficence, we all know we are physicians, we should do no harm. So when you're doing a particular research, evaluate what are the benefits to the individual, to the participant. If there are no benefits, are there risks? Would that risk be more than minimal risk? Would that risk be such that people would not want to be part of this research? If there are no benefits, important to tell the participants that look, you're not likely to directly benefit. There may be benefit, there may not be benefit, but how they are going to contribute to research, that has to be transparently and openly told to them. Lastly, justice, in the sense when you take equitable selection of participants. For example, there's a hospital or you have a clinic where you see patients who pay you, and you also do charitable work where the patients do not pay you or they pay you nominal amount. It's not fair to take patients only from that category of patients and not take the ones who are affordable type, saying, oh, I don't want to subject them to a trial. That would be unfair. Similarly, research cannot be done in countries where there is no possibility of that drug being marketed in the country at all. So use studies in countries like LMIC countries, and actually the drug gets marketed only in the Western world. Okay? In India, actually when a company applies for a new drug clinical trial, there is an undertaking which the sponsor has to give, saying that they will bring this drug into the Indian market if the results are favorable. So that is one thing which our regulators have laid down. Similarly, you cannot therefore do studies in those categories of countries of people who will finally not benefit when this drug comes into the market if it is useful. There is also a very clear distinction. I think we were talking about all of us being clinicians and all of us being able to do research. That's true, but remember when you're being a clinician, what you're doing is giving medical care. You're giving medical care to an individual patient. You're using the evidence based from research, but you're giving treatment to that individual patient, okay, and that time that human person is your patient. He comes to you for treatment, he comes to you for management. You're giving the best possible treatment based on the available knowledge that you have. You means you and your team. It could be a team of people. There could be a nutritionist, there could be a physiotherapist, there could be a nurse, there could be another resident, there could be so many other people. So that team is giving individual help or treatment to that patient. That's medical care. The treatment is flexible. You always discuss, right? You discuss that these are the various options. you know, which one can we treat you with? We have this, you have that, other treatments. Sometimes the patients decide that, no, I want to go in for this option, or I want to go in for another option. Whatever the reason, they choose one or the other, but you always discuss the treatment options with these patients. There could be surgery, or we could try to manage without surgery. If we manage without surgery, it may be that you may have to undergo surgery later on. At this stage, we have an option of wait and watch as opposed to an intervention. So that's what you're doing in clinical practice, right? Same thing here. Who decides the treatment? The treatment may be options, but finally it's the doctor who's deciding which are the options to give this patient, or to decide what treatment should be given to the patient, right? So that is medical care. But when you look at research, you're testing a hypothesis, right? So it could help that participant, it may not help that participant. But what it will do is definitely help future patients, right? So whatever questions you have in mind because of which you're doing research, you may have future patients who may benefit from this research. Remember, I said there should be a fixed protocol. So in research, you're following the protocol to the T. If your protocol says hemoglobin should be 10 gram percent and your patient has 9.5, you cannot justify that 9.5 equals to 10. The protocol is very clear. You have to use 10 and above. If it says your platelet count has to be 50,000 and above, it has to be 50,000 and above. That is compliance to the protocol. It's not clinical practice, because you're testing a new drug, a new intervention, a new diagnostic tool, whatever you're testing. So there is a rigid protocol which you have to follow. So that is where it differs from medical care. In practice, you may give 49,000 count, you may still give the drug. But in research, you cannot. You have to comply with the protocol, and which is fixed. And then the protocol decides the treatment, whether it is randomized, open label. The protocol decides which are the 2 treatment options or 3 treatment options. What are the doses? So that is the difference between research and practice, which we should be aware of. So when you look at ethical research, okay, what are you really looking at? Does your research have a scientific value? It's good to have a lot of research being done because you have seen a lot of cases, and ultimately it should have some scientific basis. Is it going to help you in your future research? How in treating your patients? How is it going to help your patient population that you see in your day-to-day clinic? Is there an ethics committee approval? Like I said, for every study, make sure that there is an ethics committee approval, because when you go for publication, when you go for presentation, the first question asked is, do you have an ethics committee approval? Even if it is your own case studies, it's your own data that you have generated, you have collected it online over a number of years, you go for publication, the first question asked is, does it have ethics approval? We've had situations where I'm an ethics committee member and the investigator comes back to us and this is my case study, they are my patients, I have seen this data, I have collected this data. Now I want to publish it and the publisher is asking me for ethics committee approval. So now give it to us in retrospect. We have faced this many a times, you know. So ethics committee approval is important. There should be a favorable risk-benefit ratio. If there are no benefits, at least there should not be major risks for these participants. And informed consent, of course, and keeping that data confidential makes any research ethically sound. Just giving you in one table the different time points when codes, standards, principles were laid down. So you saw in 47 it was a Nuremberg Code after the World War, after a court case was held in a place called Nuremberg in Germany, where all these doctors and others who took part in unethical research on these prisoners of war were tried. 6 of them got death penalties, some 15, 16 of them were given various sentences, and only a couple of them were acquitted. So then came the Declaration of Helsinki, and like I said, there have been lots of updates. Though there have been meetings held in different parts of the world, it still keeps being called Declaration of Helsinki, and the last one in 24 was again in Helsinki, which is from the World Medical Association. 1979 came the Belmont Report, and that's where I told you about the 3 ethical principles: autonomy, justice, and respect for persons, okay, and beneficence. Then came your ICH. Now I'll come to the ICH guidelines in the next set of slides. But remember, in India, we are not far behind. We also have our own guidelines and regulations for research. So the ICMR first had a position paper in 1980, and then they came out with their guidelines, which is called the National Ethical Guidelines for Biomedical Research in Human Subjects. That's the full title. Okay, it's issued by ICMR, so we conventionally keep calling it ICMR guidelines. But ICMR have many guidelines. They also came out with a guideline of ethics committee meeting during COVID times. They have recently come out with new guidelines for single ethics committee formation. So they have lots of guidelines. So remember, when we talk of ICMR guidelines from clinical research, we are talking of National Ethical Guidelines for Biomedical Research in Human Subjects. Okay, the last one is in 2017. And that's the one which we are following today. So we have ICMR guidelines of 2017, which we have to comply with in India. Then came the Indian GCP guidelines, it's 2001. It's been undergoing revisions for many, many years. It is still not come out. Hopefully, we should see the revised guidelines very soon. And then the Schedule Y, which was an old one. But now in 2019, we got the new drugs and clinical trial rules 2019, NDCTR 2019, as it's very conventionally called in short form. And then there have been many updates, which Raakhi also referred to. So when you're doing studies in India, we have to follow ICMR guidelines, and we have to follow new drugs and clinical trial regulations. Now, ICMR, though they are called guidelines, they are mentioned in the NDCTR rules that for certain types of research, where it's not a new drug research, where a study is being done by a sponsor, but all of y'all, when you want to do any type of research, then you have to follow the ICMR guidelines. So they are no more only guidelines, but they have become the rule of the land because they get mentioned in the NDCTR. So earlier people could say, these are guidelines, we don't have to follow them. But now they are part of your rule. If it's a rule, then you have to follow them. You have to comply. And NDCTR mainly talks about new drug clinical trials. That means pharma-sponsored studies where they want to market a new drug for the first time into the country. It's more applicable for pharma sponsors and then their investigators as well. Now there were all these codes, guidelines, regulations which were all there, right? What was happening is that studies were being done in different parts of the world at different time points. It was leading to a lot of duplication, triplication, lot of efforts, lot of money being spent, delays in getting a new drug into the market. So there was an international forum that was formed called International Council for Harmonization. Okay, this ICH, International Council for Harmonization, earlier term used was International Conference on Harmonization. But then they changed the name and made it International Council for Harmonization. And what was this whole council deciding upon? They said that let's create a technical document, okay, which would be acceptable to regulators all across the world, or to as many regulators as possible in different parts of the country, so that data that is generated is of a uniform standard and it will be acceptable to regulators in different parts of the world. Therefore, you don't need to replicate, like studies need not be repeated in Japan, in Europe, in USA, in Australia, in India, everywhere. You can have a global clinical trial, do it all together, apply these technical guidelines and submit the documents to the regulatory authorities and thereby get your marketing authorization. So the drug is brought earlier to the marketplace, and at the same time there's a lot of savings on the money that is spent on studies being done in different parts of the world. So that's why they formed the ICH. ICH has 4 big standards. One is what is called quality, other one is safety, third is efficacy, and last is miscellaneous. For ethics in GCP, we are considered with the efficacy guidelines. So this document actually tells you about right from how to do the studies in the laboratory, what are the in vitro studies, stability studies, humidity, all those formulation studies. Then it talks about the safety studies, so acute, subacute, chronic, reproductive toxicity, genotoxicity, carcinogenicity, all those studies come in safety. E is the efficacy, in which one small portion out of 23 efficacy guidelines, E6 is the one which talks about ethics in clinical research. It talks about good clinical practice guidelines. So remember, that is E6. Okay, and this E6 guideline tells you about GCP or good clinical practice. Here when we talk of GCP, We are not talking of good clinical practice as in your clinic, but we are talking of good clinical research practices. So GCP, though it says good clinical practice, it actually means good clinical research practices, okay? And it says that it's an international ethical and scientific quality standards. Right from the time you start planning the study till the study ends and you report it. So it includes processes all across the entire process of that clinical trial, right from how you plan the study, how you conduct it, how you record it, how you report it. It covers all these aspects, and therefore GCP is of primary importance when you're doing clinical trials. What is the purpose of GCP? Again, when you follow GCP guidelines, when you follow these scientific and ethical standards, you're ensuring that the patient's rights, participants' rights, safety and well-being are protected. What are their rights? Right to consent, right to refuse to participate, right to refuse participation after agreeing to be part of the study, their right for proper care and treatment even if they are trial subjects, safety, see that the correct drug is given in the correct dose, it is stored properly, it is given in the correct manner, they are given proper instructions on how to use this drug. If they have any adverse events, what we call side effects, if they have any adverse events, you have to take care of that, manage them, take care of them, that's their safety and well-being. Of course, their confidential data has to be maintained. Basically, their well-being has to be of primary importance as opposed to the research. So their research participation has to be the secondary concern, their well-being is a primary concern. So when you comply with GCP, you ensure that the participants' rights, safety, well-being are protected, and you're generating reliable data, and you're maintaining study quality, because you have a good participant, good consent, you have taken care of their rights, safety, well-being, but your data is unreliable, it's not credible, it's not accurate, then what's the use of that data? You do not get anything out of it. Therefore, when you comply with GCP, right from planning till the reporting time, what you're ensuring is that the participants are protected and the data that you generate is reliable, and it complies with all the ethical guidelines, international ethical guidelines as well as your local ethical guidelines. So if any of you are approached to be part of a global clinical trial by a pharma company, they will say we have to comply with ICH guidelines. That's fine. Over and above that, you have to comply with Indian GCP guidelines, because that's what written in your NDCT rules. This is for a new drug trial, okay? And if you all are following Indian regulations, so in India, what do we follow? We follow NDCT rules 2019 and its updates, okay? So this is, NDCT rules is mainly for clinical trials with new drugs. But NDCT rules, like I said, mentions two very important points. One is any trial in India has to comply with Indian GCP, and certain types of trials which are called academic trials or biomedical health research. What you all are doing is academic trials, right? They are not part of a new drug registration. So if you are doing academic clinical trials or what is called investigator initiated research, okay, IIR, or any other type of biomedical research, like two types of surgeries if you're comparing, two types of radiation you're comparing, two types of devices you're comparing, then they all become not definition of a clinical trial as per NDCT, but they all form part of investigator-initiated research. Then you have to follow the ICMR guidelines, National Ethical Guidelines for Biomedical Health Research in Human Subjects. So therefore, it being mentioned in NDCTR, you have to comply with the ICMR ethical guidelines as well, and of course the Indian GCP, it's an old one, but you have to comply with these. So as investigators, what are your responsibilities? Protect and respect the research participants, very important. Avoid exploitation. We talk about justice, right? You have to choose the right patients. Protect the vulnerable groups. Your ICH guidelines, your Indian GCP guidelines, your NDCT, your ICMR guidelines, they all describe what is called as vulnerable population. Children, always vulnerable. People with diminished capacity to understand, vulnerable. Pregnant women. It also talks about prisoners, refugees, minorities. They are all considered vulnerable groups. So be very careful. Illiterate participants, be very careful about these vulnerable groups. Comply with the protocols guidelines, report adverse events, okay? anything that happens in the study, report. Because today when you're doing research, you do not know whether it is related to the intervention or it is not related to the intervention. So report anything that happens with the participant. Many a times we hear, there is flu going on everywhere. My patient who is in the study, this participant has got flu. Why do I have to report it? You report it because you do not know whether this participant really had flu or he had something else, right? So you have to keep reporting that. Maintain accurate data. This is very important. In GCP, there's a tagline. If it is not documented, it did not happen. So document everything. You feel, I have talked to the patient. Yeah, you have talked, but if it's some auditor, somebody else who wants to check what you have done, first they will ask you is, where is the documentation? See, you all do it in your clinical practice as well, right? And that has saved a lot of you from consumer court cases where you have described 2 treatments and the patient has opted for one. If you have not documented in your case files which you keep with you, then the patient can always say this was not discussed with me at all. But you have documented it, it saves you later on. So similarly in research, document everything. Patient missed a visit, document it. Patient had any adverse event, any complaint, document it. Okay? So documentation is very important. Therefore, maintain accurate data. That's how you'll confirm that your data is reliable. And of course, transparency. I think Supe sir also said that you have to transparently tell everything to the participant openly and then take their consent and then take them as participants. So remember, participant safety comes first. Consent becomes mandatory. Ethics committee approval is absolutely essential or mandatory. Therefore, good data requires good ethics. Good science is good ethics. You cannot have good science with bad ethics. You cannot have good ethics with bad science. Okay? And therefore, if you do not follow these ethical guidelines, then your data is unreliable, your participants are not protected, and therefore it creates a lot of disturbance all around. So with this, I'm ending this thing, and let's go ahead with some questions. No, wait, there are some questions still. Yeah, you all can just use that paper and pen which you have, and you can write, say, answer is 1A, 2A, 3A, whatever is your answer. The next slide, I'll show you the right answers. If anyone would like to guess, clinical research involving human participants must primarily ensure what? C. Everyone agrees? Okay. GCP stands for? Good. I think I've done a good job. Informed consent means, this is the catch one. Is it A or is it C? C. Sure? Okay. You all are right. That's the right answer. Okay. Let's see the next one. The primary responsibility of participant safety is with whom? Ethics committee? Investigator? Okay. Which is not an investigator responsibility? Ensuring participant safety, obtaining consent, approving drug manufacturing, maintaining source records. Yeah, manufacturing is not an investigator's responsibility, right? Most important feature of a valid consent is documentation, understanding, investigator signature, witness presence. Documentation. How many say documentation? Okay. How many say understanding? Yeah, it is understanding. Remember, you have to explain everything to the participant. They have to understand and then voluntarily consent to participate. Okay? Absolutely. Absolutely. You have taken consent, but there is no signature. There is no documentation. It is not documented, it did not happen. Witness is not always required. A witness is required for illiterate participants. Okay, that's called an impartial witness.
Witness was required in some of the trials that I did.
Yeah.
Where there was a significant intervention for the new drug that we
Yes.
especially when the product is new.
Yes.
Then the presence of witness is beneficial.
No, but witness is mandatory if the participant is illiterate. And this that's called an impartial witness. The impartial witness must read, write and understand the language of the participant and reads out the consent form to the participant. Witness signature means that the witness says, in my presence, this adult participant voluntarily agreed to participate.
But madam, there is a catch by the term literacy, because most of the participants, even though they are highly qualified, are medically illiterate.
No,
So
see, that's why
that is the place where
I'll come to that. See, that way you can call me completely illiterate where AI is concerned.
Yes.
I'm completely illiterate. I'm planning to do some course just to understand what is this AI. So your informed consent form, therefore, and that can be one topic, whole session on informed consent. Informed consent, assent, audiovisual consent, a lot of things. So your consent form has to be written in such a simplified manner that a class 6 or class 7 student should be able to understand. Okay? And then you say it's a good informed consent document which can be understood, and it needs to be translated in the languages your participants will usually understand. So in Maharashtra, if you're doing it, Marathi, Hindi becomes mandatory. If your community where you practice, there are lots of Gujarati speaking patients and you need Gujarati. Like I go to Tata Hospital, there are lots of Bengali patients who come there, then we get it translated in Bengali as well. So the idea is that, and therefore your ethics committee is important. If it is not simplified, your ethics committee will refuse that informed consent document. They will say revise it. Revise it, make it simple. There are some medical terms which I know are not easy to translate. So write that medical term as it is, and in bracket you explain. Like example, you're saying gastroscopy. You write gastroscopy, but you say that a thin, small, flexible tube will be passed through your food pipe into your stomach to see the inner lining. So the participant understands, and a literate person is anyone who is an adult who can read the language he or she understands and speaks.
Yeah.
Illiterate is an adult who understands and speaks a language but cannot read.
Okay.
Yeah? Okay. So primary, I think we saw this. Okay. Now this is an interesting one. Ethics committee primarily safeguards whose interest? Participant, that's very clear. Now match the following. I think this you may need paper and pen. Belmont report, B says Indian regulations, NDCT rule says biomedical health research, ICH GCP says global trial standards, ICMR says original trial data, source record says ethical principles. Anyone wants to stand up and give me the right answers? Or should I just show them? That's my last slide. Just show them? Okay. Nobody wants to attempt this. I think I've said some of these words very repeatedly. Ethical principles, Belmont, very good. NDCT rules? Indian regulations, very good. ICH GCP? Global standards, yeah, it is the same one. ICMR guidelines? Yeah, that's why I kept telling you the full form. Biomedical health research. And source records? Original trial data. Okay, that's great. Thank you. Wonderful. And these are some references if you all want to look them up. Thank you. Oh, I don't think we need the backup slides, right? Okay. By the way, anyone wants to read ICMR guidelines, these are the ones. They're beautifully given. I think each one of you should download and read them. So beautifully given. Okay? It tells you all the processes to follow and in which type of research. So all the different types of research which Raakhi talked about. Observational research, cross case control studies, cohort studies, analytical studies, RCTs, everything. Okay? So that's it. Thank you.
Also, madam, I think it's mandatory for all the researchers who are aiming to do any studies to have a GCP certification.
Exactly,
Absolutely.
exactly.
This is
most
necessary.
ethics committees will insist on a GCP certification.
Yes.
Maybe this could serve as a GCP certification partly,
Yes.
partly. But I know most of you will land up doing one online course called NIDA.
Yes.
But that's not ideal, that's not sufficient.
Yes.
Anyone who wants to do research, there are lots of courses which are happening online. In fact, Tata Memorial is happening one online on 25th of July. You can register online. They cover many topics related to research, especially ethics in clinical research, so GCP guidelines, Indian regulations, ICMR regulations, informed consent, how to take consent or processes, all that is there. So you can go online and check that out. If you want that certification, especially if you're doing global clinical trials or even otherwise, your ethics committees will ask for it, so you get that certification. Thank you.
Thank you.
As dramatic as
No, madam.
as interesting as Nithya, but I've tried to give you the.
No, madam, but at the end of this, it is ethics committee. You cannot escape that. Even if we plan to do any research, without satisfying all these which madam has said, it is futile to even think of forming a research question. Forget about doing a.
So please form one.
Yeah. But
don't forget
yes.
Don't forget the
No, but madam,
Yes.
Sunil Gavaskar is Sunil Gavaskar, Virat Kohli is Virat Kohli, and Vaibhav Suryavanshi is Vaibhav Suryavanshi.
Just add one more thing. Nowadays, many journal editors want even ethics committee permission for case report, case series.
Yes.
Yes, in fact,
It is mandatory now.
when I was a journal editor, that time also we laid down these criterias that there are certain, especially the interventional cases, those were, controls. Yes, we insisted for ethics committee approvals, and in fact, there is a separate segment for you.
Sir, we will discuss this in the panel discussion
Yes.
right now. I would like to thank madam, and I would like to call Subhashri madam to just felicitate madam. Please, madam.
Thank you so much, ma'am.
So,
मी पण सरांना
ते म्हणतात ते पॅनल डिस्कशन नको फक्त काही क्वेश्चन्स असतील तर
No, but then we have the questions planned. We should call them.
कसं करायचं
मला वाटतं सगळ्यांना बोलूया एवढं दूर
ठीक आहे, ठीक आहे.
should get the audience in.
ठीक. So we now proceed with if anybody has any questions. We have some questions, but even audience, if they have any questions, we will be more than happy to answer them. So I call upon stage the presenters also and our esteemed delegates. I would like to call Nadkar sir, Mangesh sir and Nikhil Balanke sir. Apart from that, Nithya madam also and Raakhi madam and Dr. Durga madam also to answer the queries given by various means.
Is this on? Thank you, Dr. Nikhil Balanke, sir, for being here, coming all the way from Nagpur to attend this program. Please, a round of applause for him. Thank you so much, sir. He has a flight to catch.
Thank you, sir. Thank you. Thank you.
Now we are on the last segment of this research workshop that we are.
Agam sir.
Hold on. So we are at the last segment of this research workshop where we are going to take the questions from the audience, and we also have our own questions that we want to address to our esteemed panel. And before we start the panel discussion, I would like to again emphasize that those of you who are interested in diabetes, metabolic and obesity related research, we have a research group called as Sugar Science Studio, and the QR code is right there on the screen. If you can put that QR code so that anybody who is interested can scan the QR code and join our group. So my first question, you can do it later, I think after this. So my first question is for Dr. Natkar, sir. Sir, we are all busy clinicians. We have our day-to-day OPDs. We have too many things that we are handling. And at times, research feels very intimidating to all of us. So we would like to know that we don't have any formal training to do the research. So what is the point? What is the place there where we can start off? What do you think should be a starting point for a clinician for the research?
Thank you first of all for inviting me. First of all, you yourself should have some sort of a liking for research. Just don't do it because everybody, there is a peer pressure that, others are doing, why not me? And once you are clear that you want to do something, as I think Raakhi put it, or even Dr. Supe sir was saying, the first thing, the simplest way is to start with just a case report. That you come across, like this is, I'll talk in terms more of a physician's examples. So like you are now starting with, say, malaria now, with this season. You come across some atypical manifestation, try to get that, try to report that case, build some literature, do some good literature search, see if any other reports are there like that, do that. If you think that now my malaria cases over a period of time I'm seeing some 3-4 months, I find that this time there is something different in malaria, which, new manifestation which was not reported. Try to then build a case series. So go a little higher level. And then of course, as Dr. Supe was saying, that the highest level will be a randomized control trial, but that is in a due course after a long time, that you have developed a confidence, you have your own team in your this thing. And the bottom line in any research, of course, which is till now, I don't know, at least I have not heard anybody mentioning here, is that when you are doing a research, see that your patient doesn't have to burden any single rupee as an extra cost just because you are trying to do some research. So that has to be kept in mind, that all the standard treatment that has to be must given to any patient, your research participant. Without that, your research cannot proceed. So I think you just have to build up yourself slowly, and then I'm sure everybody will be able to do a good research.
So when we have this kind of thing where we are constantly observing, that this season the malaria is showing certain changes that has not happened any other season. Madam, at the end of it, when I realize that I have a good case series, what about ethics, madam? Should I come at that point of time for the ethics? What should I do? Because then, how do I convert these observations into a paper? Will I need ethics for this also?
See, if you have already thought about it before, that because it's malaria season, I'm going to look out for any unusual presentations. It's nice to write a simple protocol and get an ethics approval upfront. But if it is something that you have already seen, and therefore you now want to document and then present it, then you can go back to the ethics committee saying that I had not planned this study, but these are my observations, which now I want to publish, or I want to project it somewhere, or I want to present it, and then come back to the ethics committee. Because it is something very current. But if it was something that you've been seeing for the past 5-7 years, and now you are seeing this data and you want to publish it, and then you go to the ethics committee, they get a little upset about it.
Okay.
Madam, I would, yeah.
I think your question was about the ethics approval, no? Because you don't work in an institution. If I have understood your question correctly, for us it's easy because we work in an institution where we have an ethics committee. So we take what we call as institutional ethics committee approval. What you could do is we have independent ethics committees as well. Right, so you could take, or you can apply to them for ethics committee. That's if I've understood your question correctly.
Yes.
The other thing with case reports, which I would just like to mention, is we have something called as CARE guidelines, CARE, case report guidelines. So if you follow those guidelines, then your case reports get published much better. And one of the most important things in the case report is informed consent. Right, so I hope I've
Madam, you require ethics committee.
This report also requires ethical committee.
Yes. Answer is yes. And as ma'am said, ki you can approach to any whatever those independent or non-institutional ECs, but there is a caveat in that it has to be within 50-kilometer radius.
Yes,
So
there are so
you
many.
can't go to an ethics committee of Nagpur,
Yes.
and when your project is in Mumbai.
Yeah. And one
Or
more.
you can go to an institution as well and see if they are willing to take over your submission for ethics approval.
Yes.
They will request a small MOU to be in place because you have to allow that ethics committee to supervise your study, allow them to see your data, allow them to check if they've taken informed consent, submit their semi-annual or annual report. So if you're willing to do that, you could go to an institution as well and request them to be an independent ethics committee for them.
So
Will
now,
that be
now the
okay?
question is that are there any situations where you don't have to have a ethics committee approval as a mandate?
Ethics committee approval is a mandate.
It is a mandate.
Yes.
Every situation.
Even if it is observational
Even
study,
though
even
it
if it is retrospective.
Retrospective,
See, even if you're
non-interventional.
saying- Yes. If you are saying that this should be exempt from review, for example, it is stored biological samples,
Okay.
anonymized,
Yes.
and now you want to do some further studies, and the approval is already taken as a blanket permission from the participants, and you're not going to contact the participant at all. You're using anonymized sample. But getting ethics approval is mandatory.
Mandatory. Okay. Thank you.
You can say that it is, exempt from approval, but that decision should be the ethics committees and not yours.
Yes.
Madam, you said about the placebo-controlled trial, if the benefit of the drug is not that much, at what stage we should stop the trial, or the one is randomized trial with the placebo versus a drug, and the benefits are so overwhelming that sometimes they have to intermittently stop. At what stage of this placebo should be stopped actually? That's
No,
I think
see,
any
in placebo-controlled trials, usually
so
nowadays...
we are depriving certain patient of the drug
Correct,
benefit which is
correct,
available.
correct.
And that stage sometimes the placebo-controlled trials have been stopped actually intermittently.
Agree.
So is there any guideline where you should stop it actually? I'm
See,
thinking.
normally, usually nowadays, we don't do purely placebo control. It's standard of care plus the new drug versus standard of care plus placebo. Right, so that is one usual method. Unless it's a very novel drug which has never been used, then only maybe in a few select studies you may
So
do
there
a
will be
placebo
some standard
control.
of care will be there in
Yes,
comparison.
but you have to give what is called rescue medication.
In
For
that
example, osteoarthritis, you're using a completely novel drug which has not been marketed, which has not been heard of, it's a new way of treating, so you want to compare it with a placebo. So you'll do that study, but you say if there is breakthrough pain, they are allowed to take XYZ as rescue medication. That's one. It can happen in early diabetics sometimes. You do a placebo control with very early diabetics, but the protocol will have very clear guidelines on daily blood sugar monitoring or now continuous glucose monitoring. If your sugar levels go above this value on 2 or 3 successive days, then the patient is considered as having reached end point and withdraw the patient and treat them as a normal patient, irrespective of whether you know it's a placebo or not. Because it's a new drug, you don't know whether that's working as well. So protocol has very clear guidelines on when you stop the study. Yes, it could be an investigator who says that no, I'm seeing too many patients with non-response and therefore I want to stop participation in the study. So you're allowed to do that. And ethics committee can also question that from the annual report or semi-annual report that you've submitted, there are so many participants who are not showing any response. We recommend that you should.
And you said certain
Not
countries
continue
should
the
not
study.
undertake that trial. Basic reason is financial reason, or those countries are not eligible because sometimes they are very expensive initially and later on off patent they become quite cheaper, and then certain countries it can be used actually. Initially something muscular dystrophy, certain drugs were very expensive when they were patented, and then after off patent, so it should be these countries should be off. You're not taken in a trial and all at all.
See, in a trial nowadays, there is something called a post-trial access. So even after the study is over, if that patient is showing benefit, see the word in NDCT rule is benefit. They are not saying response. They are saying benefit. It could be economical benefit as well. So you as an investigator can insist that even after the study is over, this patient is not showing any adverse events. It's not showing anything that worries me about their safety. They are showing benefits in terms of efficacy or response to treatment. So they should keep getting this drug till it is in the market. And once you say that as an investigator, the ethics committee approves, the sponsor has to give the drug free of cost in a post-trial setting to these participants.
Yeah?
So we move to the other good topic. I'll go to Nithya madam itself. See, because she has taken that topic of research question. Madam, few clinicians here have asked that they have in their daily practice they find many questions which they want to answer in the form of a clinical study. So again they have asked how to form a clinical research question from a daily clinical practice type of a thing.
Yeah, you just have to put it into the format. What is it that you're trying to answer? Can anybody come up with something? It'll be easier if there is an analogy.
For example, ma'am, we have pioglitazone which may lead to anemia, and we are observing this on a regular basis that the patient are becoming anemic. Now we want to know whether it is because of this medicine or what is it. Is it just an iron deficiency anemia which is existed in Indians?
So you want to do a research study on pioglitazone
I just want
associated.
to understand whether this is a research question. Should I go ahead and look after it?
So if you're looking at a drug called pioglitazone and you're looking at the association with anemia, one of the first things you should do, I think, which we didn't cover today, is a good literature search. You must see if the topic has been studied before, is something known about it. Is there anemia associated with pioglitazone? What is written on the product label? There has to be something novel in your research question. A lot of your questions can be actually answered if you do a literature search. So if there is literature associated with pioglitazone indicating anemia, maybe you would want to just follow up a group of patients and say how much is the drop in hemoglobin over a period of time. So you're answering something else in addition to the fact that there is association with anemia. I hope that answers your question.
Yeah. The question here is, ma'am, what are the questions that we are supposed to ask? First is whether it is novel. Second is
it feasible,
is it
interesting,
feasible?
novel, ethical, relevant?
Ethical and relevant. So these are the questions we are supposed to ask. So the next question here is, we find a research question interesting, Dr. Mangesh Tevaska, but we don't know whether it is just interesting or it is publishable. Should we put an effort there or should we not? Where to stop, where to go ahead?
Since sir is editor-in-chief of Mahajapi as well as previous editor.
That's okay. I think in continuation with what Nithya madam has said, and even primarily allow me to read, basically because I just jot down, what points that I wanted to discuss with even these people. But whenever it comes to a research question, always the first question is that, is it going to be just my interest or is it going to benefit the community? Now, depending on that, that will make it, it will be just an interesting thing or is it a publishable thing? Majority of the times it is your interest to find out about pioglitazone causes anemia or not. But then is it going to really benefit and give some information to the practicing clinician becomes the whole, I would say, the crux of your research question that you are trying to raise. There are certain places where you are looking at biomarkers, like we did it in COVID times. You looked at so many biomarkers, but have they really benefited? Their fluctuations, they have benefited the people, those who are getting treatment with COVID, with whatever the interventions that you are doing. So there were some questions which were asked were of the personal interest. That makes the question interesting, but that necessarily does not mean that it is publishable. So generally, what question should be asked to the researcher himself, he or she should ask himself or herself that is it my interest that I am just going to find it out or is it going to benefit the community at large? That is my first thing that will. And then of course, if it is fitting into what Nithya ma'am talked about, finer criterias, if it is fitting into that, then probably that will become more publishable. And along with that, if there are some interesting things that you are going to come out with, then maybe probably it will become interesting also, right?
So to continue with the same, Raakhi madam, now we have that a research question has been formed about pioglitazone and outcome as anemia. So how to go ahead? Means the clinician should not get overwhelmed and he should go for a proper study design. So how would you guide him to select a proper study design?
Okay, so actually the main thing crux lies on that research question. So it is how complex or how simple is my research question. If taking the same example, if my research question was just this much, I want to find out after pioglitazone how many develop anemia. This is simple descriptive. So I will take a cross-sectional survey of my patients and all on pioglitazone and just see how many are having anemia. Matter ends there. But if my research question was association of anemia with pioglitazone. So now it depends where I want to, what type of study I want to do. So this association testing, whether I want to take anemia cases, see if they have pioglitazone exposure, yes or no, it will go under case control. If I want to see, I'm starting with pioglitazone. I'm starting with patients where I'm prescribing pioglitazone, and whether they will develop anemia or no, it will become cohort design. So it depends upon my interest of research questions. So the way I form the research question, if my research question is very simple, just anemia, pioglitazone, I don't want anything. I'm not going to that PECO or PICOT, which madam explained, to that level. Then my design becomes very, very simple. And making very simple designs, coming to sir's question which you asked, is it publishable? So when I make very simple, and this, as a reader, you will not be interested. हाँ, madam ने क्या report किया? Madam ने कुछ pioglitazone के 30 cases किए, उसमें से 14 developed anemia.
Yes.
So what? But if I'm writing, publishing a paper where it is a case control design, and I'm writing an odds ratio, 2.3. So then I will say, if the ratio comes 2.3, that means it is pioglitazone. 2.3 has the risk of, has the odds of developing anemia, versus if it was a cohort design, relative risk. So that is how I'm quantifying my association. So which becomes more publishable, more meaningful to you as a clinician in your practice?
Raakhi, just no, I am asking you.
Okay.
And just to add something to this, there are 2-3 factors which you will have to discuss in this. Is when you are doing this research, you will have to see first of all what was the basic hemoglobin.
Correct.
Already whether he started with anemia and whether there is a drop in anemia.
Drop in anemia.
That is one thing. And second thing is, how much is the basic prevalence of anemia in that particular sort of a population, and whether it gets exacerbated. So these factors also need to be addressed.
Absolutely
in
correct.
that particular.
So this is what madam told about literature review. So I am auditing my own practice, and from literature also I know what is the background.
And there also really the disease responsive for causation of anemia. Diabetes again is one of the diseases which can cause co-founding factors. So that's what the whole thing will keep on doing.
We were told that it has to be very simple. Okay, otherwise, remember there are a lot of things which go in a design. We have briefed you very simple. That this is A, this is B, this is A. But when you go to that cursive A and cursive B, they may all look very similar.
Yes, absolutely.
So we didn't go into that. We just
we'll have workshop in our Epicon 2027. Yes, madam.
One more thing before I forget, it was alluded to by both Dr. Raakhi and Dr. Durga, the case definition of anemia. What do you mean by anemia? Is it 1 gram reduction? Is it 2 gram reduction? You will have a 1 or 2 gram reduction even if once you give a blood donation. It doesn't matter. It's not going to affect the patient's quality of life. So it is far more nuanced than just the association. And you might want to look at the quality of life of the patient or the economic burden. Are you giving iron supplementation? So case definitions people forget. Drop ho gaya hemoglobin. theek hai. How much? Does it matter?
So all should be mentioned very clearly in protocol.
Very clearly.
In the protocol.
Are there any questions from the audience? We would, yes.
We are very clever in copy and pasting, but that can be easily found out with the plagiarism when we are writing the review of literature. Now we become more smart. Yes. We are using AI, we are using ChatGPT, and we are giving such a prompt to the ChatGPT to totally change the language and write down in a novel language this type and in this pattern. Now what ethic committee have against it?
So you have asked 4 questions in your 1 question. The first question you said is copy-paste. The context of the copy-paste which I was talking about, it is contextual, is to repeat something done in the developed world and see if it works in a developing country. So it is copy-paste with a good amount of intelligence. Does it work in our setting, right? So that's one. I grew up in a non-AI, non-chat GPT time, but what I would recommend is I did this course. There's something called as prompt engineering. How do you prompt that AI? So it is also important to ask the right questions of your chat GPT or AI so that you get something meaningful out of it. The third issue that you talked about was plagiarism. Yeah. So there are plagiarism software which actually check. The previous question you asked was on thesis, no? So plagiarism checks are completely different. The ethics committee will not look at the plagiarism. The ethics committee is going to look at, the novelty of your research question, but most importantly, are the participants' right, safety, well-being protected with your research question and your protocol? So 1, 2, 3, 4. There was one more part of your question. I don't have a paper. I'll come to that if I remember it.
Yeah, so in continuation with it, if am I allowed,
yes, please,
allowed to?
yeah.
So now I'll come to the, once you probably have submitted this paper to a journal, then what happens there? Correct? So that is the place where you will be almost certainly caught if you're copy pasting it. You will be caught, 100%. Right? Now there are softwares which even detect not only the correct commanded AI, forget about, lot of AI have sold themselves saying that we create a content which cannot be detected by the AI detector. But now there are AI detectors which even, find out whether you have really used this kind of commands also. So number one. And lot of these journals, including JAPI, we used a very robust plagiarism catching software which is called as Authenticate. Now Authenticate, we have used this right from the basics to now AI powered Authenticate, where even the spelling, if you change just spelling, it will be picked up by the the plaque checker. So, and we have to understand, being the learned clinicians trying to publish our work, you should be honest yourself.
Yeah, even
if it is not there, then it will just become a paper which will be, and one more publication on your name which is not going to value add to anything, either at honesty or at the publication ethics also.
But so, if we are...
Yeah. Sir, now many journals, in their checklist, they have that command that whether generative AI has been used to...
So we can declare
exactly,
it, sir,
so
that we have used
saying
the AI. We can always declare it.
I'm telling you now that now recently it is also mandatory for you to declare. It is mandatory, not only for the submission, but for also the reviewers. So whenever you are reviewing also, have you used any AI support to review the article you have been asked to review? That also you have to declare.
How difficult it is to not use AI in today's time when you're reviewing articles?
Yeah, so...
Sir, I'll just answer in this also. Sir, technically when you're reviewing an article, to what sir pointed out, as a reviewer, I'm not supposed to upload any to AI platform, because I have written, as a reviewer, I tick on that confidentiality tick. So I cannot put it on any AI platform because AI platform is public domain. And if the journal editor detects that I have done that, I can be even punished, I can be taken this. So that is there, commitment is there.
One more thing, Agam, there are certain, maybe probably the publications which may not really be so intense on the reviewer that you should not be, it is always wiser to declare that I have used an AI software to do that. There is nothing wrong in using AI. I am not saying that do not use it. There is nothing wrong in using AI. But the only thing is that you have to honestly confess that yes, I have used AI. That makes it more transparent. That also makes the editor or whoever is the handling editor to know that yes, you have reviewed it, you know that. Because a lot of times, suppose now I can tell you my example. Sitting at the Discovery Nature desk, I keep on getting the data from South Africa, Dubai, Gulf countries, China. How I am supposed to know the community cohort and the practices there? Now that is the place where I need AI to find out. So that is the place where I sometimes use these AI platforms to find out these are the areas they really checked it, and all those reviewing basics I keep on checking through AI only, surely. But then I submit that yes, I have used AI for this support. Even for the writings, if you are using AI platforms for writing, there is nothing wrong in it.
Exactly.
It definitely improves your language, the
grammatical
errors, the spellings, the referencing, the typical referencing necessities. It supports you, but it is always better to be wiser and honest to the publication platform.
Because
even if you take help in probably structuring your reply or maybe spell checks or maybe grammar, you are supposed to
Yes.
Yes,
Declare
yes.
it.
It is always better. It is always better.
Me, I just wanted to thank you, sir, because most of us still today are using AI. Sir, here. We are using AI, but the problem is everything has to be looked through the mirror of ethnicity or how genuine you are. It's a double-edged sword. You can cut yourself with it, or you like to cut someone else. Means use it for my highlighting myself that I am the greatest. That kind of, that kind of thinking. People who are actually doing research, let me tell you frankly, they are hesitant to use AI for this reason.
No, you're not. I'll say that is not completely accurate.
Okay.
Now
I may be wrong.
again come to that.
I may be wrong. I may be wrong.
We recently published, and I was one of the authors.
Okay.
On the global guidelines on the management of heart failure in obesity.
Right.
Okay. And it was absolutely very well cited. It is published in a very reputed journal.
Okay.
But the writing team has used an AI
To write.
generate to write. So it's quite possible. It's not that we as Indians do that. Globally, everybody does it.
Okay.
Everybody does it.
Okay. Thank you, sir.
Sir, one thing I want to ask is, does the ethics committee comment on whether this study is worth publishing? One thing.
That is. Durga madam.
Madam.
No, the ethics committee will not comment on
It will
whether
not
it is
comment.
publishable or not. We will, like we said, we'll look at patients' rights, safety, well-being are protected or not.
Okay.
And have you followed ethical guidelines and regulations when you've done the study? That's what we will see in your semi-annual report, annual report, and then if we monitor the site. But whether it is publishable or not is not seen
Okay,
by
once the
ethics
study is finished, do we have to submit again to any particular committee who will say that this is worth publishing in a journal?
I mean, not that I'm aware of, but the ethics committee definitely needs a complete report at the end. First thing, it needs a documentation saying the study is over, last patient, last visit is over, study duration is over, the study is closed at our site. That documentation we need, and then we need a study report, at least the summary. If it's a large, multicentric, multinational study, we at least need a summary of that study and what happened in our center.
So does the committee comment on whether study is designed properly
No.
for the investigator use?
No, the ethics committee will not comment on whether it is designed properly, whether it's reported properly. It will want that report. If it has questions on the report, they may ask that, can this be explained, or, that sort of thing. That rarely happens, but we need a completion report for sure.
The study then directly goes to journal and particular scientific journal, and their committee approves it or publishes it. What is the
That's
method?
the scientific committee's
So
decision.
that's the place where probably the journal management comes, the editors come, the handling editors come into the picture.
So I think these questions we can even have it during our lunch, and
No, but let us answer is, he was asking a very basic question. Who decides?
It's the editorial board.
Is this study publishable or not? Is it the ethics committee? Is it the writer? Is it the protocol inventor? Is it that you are asking? Right. I think that was what
Yes,
exactly he was asking.
Yes.
So it's your responsibility to think about that. This is what I am trying to do, and I feel that this can be published. Now, whether it can be published at what place and where, that is entirely up to you. And then the rest comes with the publication, formats then later on.
What does actually happen when we submit an article to the journal? Suppose the article comes to you. What happens after it comes to you?
So fine. So then there is the first phase are the managing editors. They are sitting, they'll screen first for the authenticity. So all that process happens, putting into the plaque checker, finding out whether this is a genuinely written, well documented, are there any gross grammatical errors, are the citations proper, are the referencing proper according to the journal policies. All those things happen at the level 1. Then it is sent to the reviewers. Now the number of the reviewers depend on the journals. Some journals require 2, some journals require 4. Sometimes, you know, if there is a global journal, they will require the global reviewer situation. And then once the reviewer's comments are there, then they are again sent back to you if there are any recommendations. You have to resubmit again after, you know, probably acting on the recommendations or the suggestions or the questions which have been raised by the editor or the reviewing team. And then once it is resubmitted, either it can be accepted or it can be given back to you saying that major revision is required, minor revision is required, or otherwise it is rejected.
A small question to Durga madam.
Many papers are rejected. Nearly
Yes.
90% papers
So-
are rejected at the level of handling editor.
Yes.
And,
And
doesn't
in
mean
JAPI, almost 70% is rejected at the handling editor's place.
But just
So that depends on how many articles, the
Load of the
priority,
journal.
that is editor's job to decide and the editorial board's job to decide. You know, the importance of that study during that situation. Say like suppose we were in the COVID times. Then during the COVID times, we prioritized all the COVID related studies that time because that was probably, you know, impacting the overall medical practice. So that is the way it is decided. And then some journals have a policy of sections. You know, I'll have 3 articles on diabetes, I'll have 2 articles on hypertension, I'll have, you know, 1 article on the acute situation, some on the malignancy, some on the community, depending on, or there are good numbers of drug reviews that are published, as Supe sir was talking about, the letters to the editor, the comments, everything, they come correspondences, they all will come slow, you know, on that, right?
I was
Easiest
small
answer
Thank you
to
so
the
much. No,
question.
no, we will stop here
Stop here.
because
Small question,
now.
sir.
Yeah.
Just one question to Durga madam. Ma'am, which GCP certificate has the best validity? From where we can obtain the best certificate? In case it is there.
GCP certificate is a continuous process. You have to keep on.
Yeah, so
But
it is
there are
not
some online certifications,
Yeah.
no? So
Yes,
which one
yes.
should we go for?
I cannot say which is the best,
Okay.
but if your institution or you hear of any institution conducting such a GCP course, it would be worthwhile getting that certification.
Right.
Also, it depends on what your ethics committee agrees and approves, because ethics committee needs an GCP certification. So if your ethics committee allows you to do NIDA certification, you can do that if that's acceptable. But my recommendation would be go to a good institution like KEM or Tata or any other AIMS, PGI, Chandigarh. Many of them conduct GCP courses.
Okay.
Best is there is something on the CDSCO website.
Yes.
Where they have a full 6-hour session on NDCT rules.
Yes.
Similarly, ICMR guidelines also have links where you can access this training and get certification after that. ISCR is another body which conducts many of these courses. Yeah, so you can get certification from there. It is, see, it's basically for your learning and your understanding.
Yeah.
If you're just doing paperwork for ethics committee's sake, then, you know, you can take the shortcut. But if you really want to learn about it, this would be a better way of going about it, is my suggestion.
And a lot of times, madam, the study sponsors, they have their they have their GCP platforms
Trainers.
recommended, and you can go there. And mind well that, you know, depending on your study extents, you know, whether it is a local study or national study or an international study, whether it is a phase 1, not phase 1, but at least phase 2, 3. Now all these things, the GCP certificates will be decided by the sponsors generally,
Yeah,
most
the
times.
sponsor will do that,
Yes.
but they will focus on ICH GCP.
ICH GCP.
If it's
And
a
most
global
of the-
study.
most
But
of the
you
global
have to
studies.
learn Indian GCP
Yes.
and Indian regulations.
ICMR.
So for that you need to have some training done in India as well.
Yes, and in fact, when we did, now, for example, we did one study for phase 2 study for the, you know, dose finding study which was there for a new formulation of insulin which was looking at 333 units of insulin per ml. Now that did not get through, but that time the ICMR recommendations were mandated for the people, those who were participating from India, along with the global GCPs. And the validity is not more than 3 years for sure.
Okay.
So every 3 years, generally why? Basically because you are not expecting the study to go more than 3 years.
Right.
That is what is the general.
Right.
Also, if there are updates, you need to be aware of these updates. You know, so updates can happen before that 3-year period expires.
Right.
Also see your institution ethics committee. If their mandate says GCP certification every 2 years, then you
Yes.
need to
Yes,
have
you
that
need to have
every
2
2 years
years,
as
yeah.
well. So, you know, multiple things to be considered. Your your ethics committee SOPs, any updates, whether you want to do it for your own learning and better patient management and better research management, then do these courses like I said.
Thank you, ma'am.
CDSCO website and ICMR website are very good.
Thank you so much, all the panelists.
GCA E3. Sir, we will mandate E3 to come in the certificate.
Yes.
And your NIDA doesn't specify E3.
E3.
So the ethics committee will not accept that certificate. I'm just telling that. This is how it works at ground reality. Yeah.
Thank you all the panelists for that lovely question and answers, because most of the queries have been solved now. I would like to thank all the panelists and Shubhashri madam, if you can just felicitate.
I would like to call upon stage Dr. Agam Vora to felicitate Dr. Mangesh Tivaskar, sir.
No, wait. But before we actually officially land up into, giving the thanks, let us first give a big round of applause to Subhashri and Rakesh.
Yes.
Outstanding performance. I was like, outstanding. And of course, my humble bows to all the three champions. You rocked. Honestly speaking, this topic is an absolutely desert topic. People, they don't like to listen.
Sir, बाजू वाले इकडे आले हैं, एलर्जी वाले इधर आ रहे थे.
To keep it interesting, going, audience involved, all four of you done a magnificent job. The words are short to express my feelings for you. So
really,
it was wonderful. Thank you very much.
Thank you, madam.
Huge round of applause for both of you.
Thank you
Yes.
so much, sir. Thank you.
Thank you, sir. Thank you. And to Nadkar
I
sir
would
also.
like to call Dr. Milind Nadkar. And I would like to call Dr. Ramesh Dargar to felicitate Dr. Milind Nadkar, sir. Bouquet दीजिए sir को. Hello, sir. Sir, he is senior physician here, sir. He mentors our physician group, sir.
Now I would like to thank first of all Shubhashri madam. Like, she started, it was her baby, it conceptualized by madam's thought that let us have a program, and thanks to all the members of MS API, Agam sir, Mangesh sir, Nadkar sir, Balanke sir, Amit sir, we all supported madam's cause, and we had now such a beautiful session here. I would like to thank from the bottom of the heart Nithya madam, Raakhi madam, and of course Durga madam, Avinash sir, Supe sir, that we could, because in such a short notice madam prepared such a beautiful program, and I think everybody enjoyed and had a good...
First, Rakesh, let us thank every one of them.
Yes, all the delegates to attend such a program.
Sundays,
yes.
And not only that, madams, you'll have to promise us that this will continue as a continuation of this venture. Now this was the basic thing. Now, so slowly let us continue this doing this venture.
And of
so
course,
we want a promise from you people that we will continue to keep on doing such programs. And Shubhashri will need to really take the lead in this.
Yes.
And let us take it to a different level. And of course, USV guys.
I would like to thank that academic support which USV guys have given, especially Farida Hussain madam, Monal Patel, Yogendra Singh, Sambit Das Gupta, Vikas Yadav. We have troubled them at middle of the night also, and they were so prompt to reply. Thank you so much USV team for this academic support. Let us now come over for lunch. Thank you so much. Thank you.